Okay.
Otherwise, it's difficult to manage work and this thing. We don't have a kind of dedicated space also.
Okay.
If it's a departmental conference, then we can hire a place, which is education section place, which is a concealed room, and then otherwise our cubicles will not allow us to actually do talking from the cubicles. Yeah, they're half walls.
Okay. The other guy will get disturbed.
Yeah.
So now everybody from the old lot is over, na? They've all retired and gone, na?
Yeah.
Dr. Khane was the last, I think.
Dr. Khane, Dr. Jambekar, Krishnamurthy, Borges, all
gone, na? They've all finished.
Sangeeta is head. Sangeeta is head now. Yeah. Sangeeta is head.
Sangeeta
is head. Gujaral is the second person. Tanuja, if you remember, Tanuja is
she came from 19.
Yes. She heads the biochemistry portion, biochemistry department. And Mukhtar Ahmadwar, you may have met originally from Nagpur, time in UK, and now in TMH for last 20 years now. Yeah.
Okay. Sangeeta and that other lady, I know. Apart from that,
Tanuja, you'll know.
Tanuja Sheth and Dr. Sangeeta.
Yeah.
But all these post-retired people are still practicing, isn't it?
Yeah, Dr. Borges and Dr. Khane is practicing. Dr. Jambekar is not practicing.
Achha, she is
not practicing.
What about Chinoy?
Chinoy is practicing in Prince Ali Khan Hospital. And
even Dr. Soman Bhai must be still
Soman
there.
Bhai, part-time SRL.
SRL,
Krishnamurthy does some consultation in Bangalore.
Yeah, I know. She shifted to Bangalore. Soman madam cannot leave her lymphoma. RSL this laga.
Correct.
Need bug.
Yeah.
वो भी scanner डाल के. Scanner view में she wants you to say RSL. And even type the Hodgkin's lymphoma.
I know. Anyway, Gautam, is it I think time 1 minute past 2 o'clock?
Yeah, even on my computer it says 14:01.
Yeah, Gautam, are we
should start
now?
Hey, how many people are there in the audience side? Gautam?
Bashir?
Bashir and how many people are there on the audience side? Check.
Several delegates attended and found it actually very useful. Yesterday was focusing on histology, cytology, and hematology, including CBC and coagulation. And today, the entire day is devoted to medical microbiology, serology, and molecular diagnostics of infections. Dr. Iyer will conduct the course, and he will show and deliver lecture as well as videos, and it's essentially hands-on program. So without further delay, I will hand it over to Dr. Iyer. Just one request to all delegates that please give your feedback so that we can look after if there's anything else to be improved or any few further topics that can be added. So this is a sincere effort on our part. We both represent Royal College of Pathologists in Southeast Asia region, and I welcome people from outside India also. There are people from Sri Lanka and Pakistan also joining. Royal College of Pathologists has sponsored this program, and we welcome you all. I also thank Video Technologies, who are our IT support, for their technical support. So thank you, and Dr. Iyer, over to you.
Yeah, sure. Good afternoon, everyone. And we welcome you to one more meeting where I'll try and focus on some of the basic stuff now this is a list of presentations which has been tailor-made for handling and processing various clinical specimens in microbiology and serology. I've also tried to include one small presentation on parasitology because that's something which gets missed out time and again. I've also got some videos, particularly focusing on those specimens which are always a problem. And those are the places where technologists and probably laboratory supervisors, those who have been working in microbiology and serology, need to focus on. There are time constraints, and it is a huge thing to be covered in about 3.5 hours, because we need to give at least about 15-20 minutes for questions at the end. I can't be having a monologue over here for 4.5-5 hours. And anything to do with the Royal College is always time bound. We are supposed to start on time and finish on time. So unfortunately, I'm quite known in microbiology circles to go on and on and on and on from 8 a.m. till about 6 or sometimes even 8 o'clock in the evening. But then today that may not be possible. So and another thing is I have got a small video on molecular, but then I'll just sort of try and, I'm not going to focus on molecular at all today, because molecular is something which needs 4 hours on its own. So I thought it's much better to do microbiology and serology very well and try and focus right from basics to some tricky areas. And more importantly, I want people asking questions, particularly technologists in microbiology. It is unlike hematology, unlike biochemistry. This is a science where manual dexterity plays an extremely important role. And if you're not very careful about that, the way you choose a sample, which samples you select, which samples you reject, if that is not known, then we're going to have problems at the end of the day. So with those few words, I must thank the Royal College for having thought it appropriate supporting our initiative in talking to our technical colleagues on this very important topic. I'll share my first presentation. Can people see the slides? Kedar, you've muted.
Yeah, we can see the slides. You can make it a bigger circle. Yeah, that's fine.
That's fine.
That's perfect.
Okay.
Yeah, perfect. Perfect.
Right. Now, there are some of the unique features for a microbiology lab and clinical specimens. A very important thing to be remembered is you cannot duplicate a sample in many instances, unlike other branches of pathology. For instance, if you have a blood sample which is a problem, why? Because it got hemolyzed or it's a lipemic blood sample in biochemistry, you could go ahead and collect another sample. You could also collect another urine specimen for a routine analysis, but then here you can't collect a CSF once again for culture once it's come in. You can't have a tissue once again once it's come in for culture. It's also difficult to get some of the body fluids, particularly the ones which are not easily accessible, pleural fluid, for instance, pericardial fluid, and so on, synovial fluids, and so on. So samples cannot be duplicated so very easily because they may not, even if you try to duplicate a sample by recollecting a sample, it may still not represent the same kind of material which the first sample may have represented. Collection, storage, and transport of specimens, therefore, have got a great bearing on what final reports emanate from a microbiology laboratory. So it's not just sort of how you handle specimens, it's the whole story starts right from collecting a sample, how are you going to store it pending transport, how are you going to actually transport it, which samples and in what condition reach the laboratory and in what time frame. Time frames have got a very important role in microbiology to many other branches of laboratory medicine. And finally, of course, adequate volume, clinical history, all of those things are much easier said than done or even understood. So it's very important for us to remember these kind of things when you're talking about clinical specimens and the microbiology laboratory. So therefore, we have something called a sample acceptance criteria. Now, those who have participated in accreditation processes, those who have prepared for an NABL accreditation would have already known these kind of terms, wherein you call of sample acceptance and sample rejection criteria. Sample acceptance criteria are basically those which say that this sample has been collected appropriately in the correct container, which is sterile and sealed with a tight-fitting lid. All of these are extremely important. You collect a sample of great importance for microbiological cultures and put it in a saline bottle. It is of no use. After using the saline, you just decant it, or you use it, or you put it in a Vicks bottle and get it. All those are not acceptable. Similarly, you put it in a sterile container, but you leave it open. Even that is not done. You must have an appropriate request form that is filled out with patient details that have been entered correctly. Now, without a request form, a specimen in any laboratory branch means nothing. So it's very important to have this request form along with appropriate and relevant clinical details. A representative sample from the site of infection collected in the most minimum possible time for microbiology analysis is what we look forward to. Now, this is very important. The site of infection is important. That is because a lot of organisms can be deciphered from the site of infection. You don't think of group B streptococcus in a synovium. You don't think of Streptococcus pneumoniae in urine. You don't think of Haemophilus influenzae in anything else except a sterile body fluid, a CSF, a sputum sample, lower respiratory tract secretions or blood cultures, for instance. You don't go looking for Haemophilus influenzae in fecal microbiology, definitely not. So it's very important to know what is the site of infection, what is the type of sample collected, and how long has it been left out. Now, this is something which is of great importance. I'll come to this a little later. All right. By the way, just like yesterday, people could type out their questions in the chat box. And at the end of the 1.5 hour session, I'll try and answer as many questions as possible before we break for tea. Now, similarly, if the details of the patient on the container do not match those which are there in the request form. Now, this is something which technologists and microbiology personnel, laboratory supervisors, and so on will face day in and day out. Many a times you find it's Mr. and Mrs. something. It's a male patient's form accompanying a female patient's container. So all of this can happen. The age doesn't match, the sex doesn't match, the site of infection mentioned on the request form does not correlate with what is there in the container. The sample is being collected and stored and transported to the laboratory in an inappropriate manner. That means if you look at the sample collection criteria to be written in the manual for an NABL accreditation, the common thing is there must be, from the point of origin to the receipt of the sample in the laboratory, there has to be a temperature control, there has to be a time control. This is done with some kind of thought process. That is because we would like most of the samples to be delivered to microbiology within half an hour. But then this is easier said than done, as I've already said in a previous slide. Many times you get specimens sitting on the clinical counter, on the ward counter for a good 4 to 6 hours, and then slowly they walk into microbiology. Now, depending upon what the specimen is, you may accept it with a comment, you may reject it outright, or sometimes you may have to talk to people on the phone to be able to gain knowledge, because there can be various permutations and combinations. Somebody may sit and raise a requisition at say 8 o'clock in the morning, but then your sample is collected at 12 noon and then it reaches the lab at 2 p.m. So the time of collection to the receipt is obviously not 6 hours, but then it's just about 2 hours. So that particular thing is extremely important. A telephonic conversation becomes very important before we start rejecting very, very important specimens like CSF. Samples with obvious contamination naturally need to be rejected. Like for instance, if you have feces dropped into urine in a sterile container, you obviously can't go around collecting that particular sample and transporting it and expect a microbiology report on a urine culture with fecal contamination. So therefore, which of the specimens refrigerated? Now, suppose if you collect samples and there is a pending time for transport, which are the specimens? What will you do with them? If it's a urine sputum, all catheter tips, feces, except if it is for Vibrio or Shigella, in which case you cannot refrigerate them, all nasopharyngeal aspirates and samples for chlamydia. These are some of the specimens that are between. On the other hand, there are some samples which you dare not refrigerate. You cannot put them in a fridge and expect very good results out of them. The worst case scenario is taking a blood culture bottle out of a fridge, collecting a blood. Even if you collect, I mean, everything else is perfectly okay. The preparation of the site is okay. The volume collected is fine. The timing of culture collection is perfect. Everything is perfect. But then the bottle, the container receiving the sample is bad. First of all, it is cold, and you go and put warm 37-degree blood into it, which means any organisms which are present in the blood are going to die off, or they get stunned because of cold shock. They go into a state of shock because of the cold. The broth inside is cold. So therefore, immediately go and put them, they will not start growing. There is no adapt themselves to the improved environment inside the container and start growing. So the log phase comes much to what should have actually happened. Or sometimes, or still worse, so certain organisms, delicate fellows like Neisseria meningitidis, Streptococcus pneumoniae, Haemophilus influenzae will just refuse to grow. So despite having bacteremia due to these organisms, you will get negative blood cultures. The same thing holds good for body fluids. You collect CSF and put it in the refrigerator instead of an incubator, then and then you transport the specimen after 8 hours, you will neither get polymorphs nor will you get organisms growing out of such body fluids. All samples which are suspected to contain Neisseria and Haemophilus, that's the example which I just gave you, something which has got delicate pathogens like Neisseria meningitidis or gonorrhea, Streptococcus pneumoniae or Haemophilus influenzae and parainfluenzae, the entire lot, Bordetella pertussis, all these are organisms which will not stand refrigerator temperatures. All purulent exudates and wound swabs, do not refrigerate them. Then what do we do with them? Either put them in an incubator which works somewhere between 35 and 37 degrees because that's the body temperature. So therefore they adapt themselves to grow. Or the other option is if you're working in a laboratory which doesn't have an extra incubator, you could share an incubator. Or if you're not allowed to share an incubator because of interpersonal problems, then at least leave them out on the working table. Don't put them in the refrigerator for organisms to die or get stunned of cold shock. So it's very important to remember this. Samples which need refrigeration and those specimens which you should not be refrigerated. I'll just dwell a bit on blood cultures. How should blood cultures be collected? It's very important because it depends upon what kind of containers you use. There are laboratories which still deal with manual blood culture bottles, whereas most of us have shifted to automated systems, be it the BacT-Alert or the BacTech, or other systems from various other companies which are capable, which are essentially continuous monitoring automated blood culture systems. So, what do I mean by this? You have a blood culture bottle which can be barcoded and put inside, and that's all that you need to do. You will get results coming out on their own at the end of 24 hours, 48 hours. It depends upon how long you want to keep those blood culture bottles. Most of the systems are programmed for a maximum of 7 days. Many laboratories use a 5-day protocol. Nothing wrong about a 5-day protocol, except for the fact that Some slow growers, relative slow growers, I mean, particularly in patients who have been on antibiotics, having a Streptococcus pneumoniae, pneumococcus in the blood, or if there is a Haemophilus influenzae in the blood, or if you have a nocardia in the blood, that may not grow so fast. Brucella anyway will not grow so fast. You will definitely need about 15 days incubation for blood and bone marrow cultures for Brucella. Any bone marrow culture must go in for 15 days before you report anything as no growth. It is criminal to keep a bone marrow culture for just 48 hours and 72 hours, do a manual plating and report it out as no growth. It definitely needs to go inside a blood culture bottle, whether your patient pays or does not pay. Now, that's another thing. I'll just come to that a little later. This is another huge problem that we work with. And unfortunately, many of us fall prey to this, that patients have not paid. There is no requisition raised for automated blood cultures. They have to raise a requisition, then only I will do a automated blood culture. Otherwise, I'm just going to put it into a Castaneda bottle. Yes, Castaneda bottles were wonderful in the 60s and 70s, but then no more today. You could follow any kind of reporting format for blood cultures. Some of the laboratories like ours, we give out a report at the end of 24 hours, 48 hours, and a last report at the end of 7 days. While I know some of the laboratories just give out one single report at the end of 7 days, there are some who give meropenem. One single dose is good enough to stun these organisms. Haemophilus influenzae is another organism that I would say. Brucella, all organisms belonging to the Brucella genus are fastidious organisms. In addition to them, I think it's very important for us to talk to them. So many a times it's much better, particularly if you have a request for a fastidious organism, it just says query AFI of more than 15 days, or query acute febrile illness in a patient, in a child, of more than 10 days duration. You would, I'm sure you would want to know what's the reason. Have they worked up anything else for the PUO, pyrexia of unknown origin? Now, all these PUOs is where you get many, many blood cultures, one following the other. And if there is no documentation, or if there is no history taking, if there is no conversation, then obviously you would just be mechanically reporting a few dabbas coming in and a few pieces of paper going out. Now, this is not what is actually required. What is required is good patient care, and good patient care requires a lot of talking and conversation with clinical departments. So phone the lab and phone the clinical departments is a dictum which everyone should follow. We do a semi-quantitative culture of urine. There is a significance to colony counts, but then it's very important that you don't follow the 10 to the power of 5 as a significant colony count in all cases. In fungus, you may not get a 10 to the power of 5, particularly in a child. But then if you do an ultrasound bladder, you will find fungus balls in the bladder. Then even a 10 to the power of 2, or even if you get a couple of colonies of Candida, it still is very important. You may not get, your colony counts of more than 10 to the power of 5, please remember, is only applicable to a woman who is sexually active, age group, and who suffers a urinary 91, to be precise, on about a patient who had undergone surgery and had a bacteroides BVS isolated from the urine culture. And it was being questioned as to how can this be a non-sporing anaerobe and how can it cause a UTI. But then after a lot of literature search, now in those days, you didn't have Google Mama, you did not have, PubMeds to search. You had to go looking at Index Medicus or write letters to your colleagues abroad. And has anybody else seen? And yes, there were a few replies which came from England saying that they have also come across non-sporing anaerobes causing urinary tract infections. But then suprapubic bladder aspirate will be the only method of proving or disproving anaerobic bacterial infections of the urinary tract. Please remember that. The way by which neonatal urine cultures and pediatric urine cultures are dealt with is entirely different. You can have a pad urine, you can have a bag urine, you can have, a bag urine in the sense, I don't mean a catheter which is connected to a Eurosac bag. What I mean is a small bag which is taped to the navel of a neonate. That is how urine cultures are collected. And as soon as the first urine is collected, tape is removed and the bag is sent off to the laboratory. Or still better, it is transferred into a sterile urine container and then transferred to the laboratory. Pediatric urines can either be a suprapubic bladder aspirate, it can be a pad urine, it can be an in and out catheter. An in and out catheter is really wonderful. It's a very, very good alternative to clean catch. Can you imagine a 10-month or 11-month infant or a 2-year-old child running around all over the house, and a mother says that I've collected a clean catch urine specimen? It is just not possible. We all know that it is not possible, but still patients sometimes, and even clinicians sometimes persist in saying that it's a clean catch sample. It is foolish and sometimes very, very spurious to report urine culture reports with significant colony counts on such specimens without adding a remark saying, please collect or repeat your urine cultures by this particular method. All right, so these are some of the ways by which urines can find their way to the laboratory. In addition to the clean catch, you can have collection at home by the patient, a catheterized urine specimen, which is preferably collected by the closed method. We no longer disconnect the Urosac bag with the Foley's catheter and clamp the Foley's catheter, release the clamp and allow urine to flow out. You can have neonatal and pediatric urine specimens. I think I just dealt with that. Cystoscopic and uretary collections are always done intraoperative. When they, when there is an investigation into the ureter, particularly, that is when the first collection is a cystoscopic urine, and then after that from the bladder, and then once you have the catheter going inside either of the two ureters, then you be prepared for any ureteroscopy. If there is a ureteroscopy, then you will always get two ureteric specimens, the left and the right ureteric specimen. If you get only one, then I think it's very important for us to phone the surgeon and find out why they sent only one when they should actually be sampling both the ureters. A suprapubic bladder aspirate is very rarely done in an adult. It's the usual method of choice for investigating pediatric, neonatal, and infantile urinary tract infections. What happens when you have to do AFB? That's for tuberculosis. Gone are the days when you have one big, kerosene container being given to a patient and you say 24-hour urine collection. That is no longer acceptable. It's very important to collect at least about 100 to 150 ml in a sterile urine container. Now, this is something which you must have. High Media has got very good sterile urine containers with a capacity of 150 ml. And unless your sample collection facility has this, there is no way by which your adult patients are going to be able to give you a good urine specimen, because it's got to be the whole of the early morning specimen collected into a sterile container. Today, tomorrow, day after, like that, 5 morning samples, and all of them are pooled. And then we handle that in a very different way when we have to do a tuberculosis culture of the urine. Body fluids, well, you can have any kind of body fluids, but then most of them are dealt with in almost the same way, except the CSF and CAPD, continuous ambulatory peritoneal dialysis. So when I talk about handling and processing of samples in the laboratory, I'll dwell a bit in detail and also try and show you some videos on CAPD and CSF cultures. Okay, feces. Now, this is something which everybody says stool culture, stool culture, stool culture. But then it's very important to note that you must be screening for as many routine pathogens in fecal cultures as is possible. A second thing is, where feces cultures are very important is when you need to screen special patient populations. What do you mean by special patient populations? Patients who are in the ICU, patients who have been recently operated upon, when there is a chance that or a risk of a patient developing a Clostridioides difficile colitis. If a patient, if you get a newborn fecal sample or a rectal swab who is housed in the NICU, patients who are particularly children who are, who come in and out of the hospital many times over with ALL, AML on cancer chemotherapy. Those are the type of patients, or your solid organ transplants and hematopoietic stem cell transplant recipients. These are the special patient populations that definitely one needs to know what a patient is suffering from. The primary diagnosis becomes important in each of these situations. And it's very important for us to sit up, take notice, because you don't just do a stool culture, you also need to look for other kind of pathogens, both parasitic, viral, as well as do an antibiotic screen for carbapenem-resistant enterobacteriales, as well as vancomycin-resistant enterococcus VRE screen in many of these situations. When do you take a rectal swab? Rectal swab is taken particularly in neonates when you want to do a surveillance for an outbreak of Candida auris, or if there is an outbreak of a VRE, or if there is a suspected outbreak of anything else, say an MRSA or a carbapenem-resistant Klebsiella pneumoniae, which is supposed to have just gone across the entire ICU unit. And of course, stool for coccident parasitic infections and microsporidiosis. This is something which we do in all our under 5s. All our under 5 stools at the Rainbow Children's Hospital, all stools that come to that place always get a modified Z-Nielsen. And we had a publication on this also in the PIDJ, Pediatric Infectious Disease Journal, wherein we got, out of many, many thousands of samples, we got at least about 1.5% of the children actually suffering from cryptosporidium diarrheas. Immunocompetent children suffering from cryptosporidium diarrheas. Now that's very important, because these children, if you don't give that information to a clinical department, pediatricians would just dump them with antibiotics. Whereas we all know that an immunocompetent child with cryptosporidium diarrhea does not need antibiotics, does not need even antiparasitic medications. It's a self-limiting illness. Same thing holds good for all patients less than 3 years. We always do a rota antigen assay, because the rotavirus is something which is very important as a diarrheal pathogen. And many times you get nothing in bacterial cultures, but then the rota antigen is positive. It may also be very important, again, to be, if you're able to do adenovirus, if you're able to do norovirus, these are some of the other viral pathogens that one should be very careful about to screen in these patients. When we have specimens coming from the lower respiratory tract, be sure to accept sputum, endotracheal secretions, tracheal aspirates, bronchoscopic aspirates, bronchoalveolar lavage fluid, and if you're still luckier, then if you're in true luck, you would get lung tissue. But then I don't really enjoy doing lung tissue, because you just get one small core. If you've seen a liver biopsy, the same is or still lesser is the volume of a lung tissue. It's much easier to do lung tissue histopathology and confirm your diagnosis, correlate it with your microbiology findings, rather than to get those small bits and pieces of lung tissue and then not really do a good job of them. It's much better to do histopathology on these very, very small core biopsy specimens. Right. It's very important to reject obvious salivary contaminated specimens of sputum, and that is what we get day in and day out. So it's very useful to do an initial gram stain, count the number of polymorphs versus the number of epithelial cells, whatever, whether you use a Bartlett score. We use a Bartlett score in our lab, but then you could also use a Murray-Washington score, or any other scoring system that one feels very comfortable. These two have been standard systems that have been described in various textbooks of medical microbiology, particularly, I think, Kohneman and even Bailey and Scott. So it's very easy to have this, but then please remember, you can't apply these to all conditions. You cannot apply it to a post-operative sputum. You can't apply it to a sputum coming from a patient of tuberculosis, nocardia, or fungal infections. You cannot apply it to a febrile neutropenic child with ALL or AML, because there you're not going to have polymorphs at all because of the neutropenia, right? It's foolish to apply this, en masse to all sputum samples that come in all patients to the laboratory. So it's very important, again, there is a role for knowing history, knowing your patients before you start looking at their specimens. Otherwise, it's as I said before, it's just a few containers coming in and a few pieces of paper going out. Endotracheal secretions and even some of the bronchoscopic aspirates are all collected in a Leuken strap. Leuken strap is something which you have a small container with a tubing outside. That's a Leuken strap. Sometimes even the tubing is chopped off and all that you get is the Leuken strap. Bowel fluids can also be transported in a modified Leuken strap, and the whole thing comes in with fluid. And that is something which is very important. Also look for any floating matter because that could be lung tissue. It's very important to be aware of this. From the upper respiratory tract, what we normally get is throat swabs, oral swabs, paranasal and nasopharyngeal aspirate. And there is a particular method of processing this. All throat swabs in our laboratory, we do an initial streptococcal grouping, particularly at Rainbow Children's. In the pediatric unit, you need to follow something which is slightly different from how you would deal with the throat swab from an adult. And it's very important, again, it's very important. When you're dealing with throat swabs with streptococcal infections versus gonococcal infections versus diphtheria versus body telepertussis versus viral pathogens, throat swabs from febrile neutropenic children, from the hemat-onco unit, and so on. So it's very important to be aware of what you want to look at, what is your target organism, and why is a throat swab done in that particular patient, except for revenue generation. That's not the only idea for doing throat swabs. It's very important to be aware of why a throat swab has been sent for this particular patient. Keep asking yourself that question, why, rather than mechanically saying, okay, a throat swab, I would put it down to these two plates, do one smear. Why? Because somebody will shout at me if I don't make a smear and then throw off the rest of the swab. It's very important. Nasopharyngeal aspirate, I don't need to go on this because it's become very popular with the COVID pandemic. Purulent exudates, it's very important. Sometimes you do get very, very little bit of the pus sample in a needle and syringe assembly. And that can be used for anaerobic cultures if the piston has not been drawn far too long to have air over there, because any air will contain oxygen and that may be detrimental to non-sporing anaerobes. But otherwise, you can't use wound swabs for fungal smears. You can use it for fungal cultures, provided there is some material sticking onto your swabs. Definitely, there is a way by which wound swabs can be used for tuberculosis cultures. We need to get rid of the Pseudomonas, which would have been picked up when you go sweeping the swab at the edges of the wound. That's where you get a whole lot of Pseudomonas colonization. And there is a way by which you use 5% oxalic acid. I don't know how many of you all have got access to a 1993 edition of Stokes Ridgway book, Processing of Samples in Clinical Microbiology by Joan Stokes. I'm sure everyone has heard of the Stokes method for antimicrobial susceptibility testing. That same Professor Stokes had also written a book, which I have one copy because we used it. That came up when we were in our final year MD. And I guard that book with all my life. I would give my life for that book because it's such a beautiful book to have with you when you're trying to do handling and processing of clinical specimens. Each of these kinds of purulent exudates will have their own kind of reporting format. Right, then there is a way by which you also look at intravascular devices. We do still do semi-quantitative culture of the catheter tips by rolling them onto the blood agar plates. That's called as the Mackey's roll method, the Dennis Mackey roll method. And then we also do a quantitative culture by inoculating, by pushing in a certain calculated quantity. In our lab, it's about 4 ml. You can use 2 ml. There are some labs which use only 1 ml of the broth. And then you push it. So that's the lumen of the catheter or the central line tip. That's what will have biofilms of organisms, and that gets dislodged when you force a fluid through the lumen of the catheter. So this is a quantitative catheter culture, and then you do a 1 in 10, 1 in 100 dilution and plate it out. If time permits, I'll just try and show you something like that. Correlation between catheter colonization and a bloodstream infection. Now, this is something which is very important. quite some time back, there was something called as DTP, differential time to positivity. You collect one blood culture through a central line tip, you take another one through a peripheral venipuncture, and then the time for flag off should be not more than 2 hours. That is when you say that this bacteremia or bloodstream infection in this patient is because of the central line. Now, there are some, this has become debatable in recent times. And again, there is a thing which says that if you are able to grow the same organism with an identical antibiogram from the central line and from the blood culture, that's good enough to stamp a diagnosis of intravascular device-related infections. Right. So I'm going to stop this presentation sharing and get on to the next one. I'll try and focus a bit on basic inoculation techniques. I'm going to do that before I get on to anything else. Basic inoculation techniques. Many of our technical colleagues, I'm sorry to say this, it's not that you are bad technicians. Your technical, our technical colleagues are very good. Unfortunately, when they, when you work, everybody likes to talk, everybody likes to chat, everybody likes to laugh. But then please remember, every time you talk, chat, and laugh, you're also introducing contamination onto your culture plates and onto your samples. Every time you talk, laugh, smile, crack jokes, you get disturbed by something that is going on around you, or you try to listen to music, or you try to see, a serial on a mobile phone, and also work at the same time, enjoying yourself. Yes, you're enjoying yourself, but then please remember, you're at a very great risk of adopting wrong techniques of plating and various other things. Now, I'll just get on to some basic techniques of plating. The first one is, one sec. Yeah. The first one is called as the streak method. Now, this is the commonest procedure which is done in the lab in microbiology. All specimens is what you call plating out onto culture plates. Now, when we say plate this out, what I mean is streak this out, right? But then there are various methods of streaking cultures, and it's a matter of personal preference, provided you follow certain rules. For instance, you heat the loop in between the primary and the secondary streak. You don't introduce any contamination. You don't go, without heating the loop, you don't go dipping into the dabba once again. The third thing is you should be covering at least 75% of your agar plate if you want isolated colonies for an antibiotic susceptibility testing on day 2. It's very important for us to remember this. It's important to sterilize the loop. Now, if you see the top photograph here, this shows the handle with a nichrome wire, right? So this part of the loop is changeable. This can be changed, whereas the handle remains the same. So what we do is, as soon as the loop part of it gets crusted, you could take this out and fit in another nichrome wire. You should be aware of the different parts of the loop. That's the first thing. It's just because the loop becomes bad at this tip, you don't throw the whole thing. The loop holder can still be used. You need to hold the loop at the correct angle, 45 degrees, or still better, straight, upright down. These are the ways by which you hold a loop. There are various people who sit with the loop like this. The flame is here and you sit like this. That's because you're so tired at the end of the day, you don't feel like holding it straight upside down. But then that's not the way you do it. Or you keep, or still worse, you keep the loop over there and you go have a cup of tea and you come back to see that half of the loop is already burnt and black. Now, these are things to be remembered when you're trying to sterilize a loop. The whole wire portion has to be flamed. It's not just this tip which is to be flamed. And that is why I said you need to hold it either at a 45 to 60 degree angle, or still better at a 90 degree perpendicular angle, because that is when almost the entire part of the loop, will be flamed, will be sterilized without heating the rest of the loop handle. Take care not to heat the shank. This is the shank of the loop. The place where my cursor is pointing, that is the shank. This is the loop. This is the loop holder. This is the actual loop. It's very important to be aware of possible burns, particularly when you are trying to deal with gas stoves and gas burners. Many accreditation processes don't agree to gas burners, but then still, without a gas burner, yes, I mean, you have those heating devices into which you can go stick a loop and hopefully get it sterilized, or you can have disposable loops. All those things are possible. But then when you have to prepare and pour media, you definitely need a flame. Inoculating loop. The top portion is made up of either nichrome, platinum, or at least of iron. The best is platinum. The common man's material is nichrome, and the poor man's material is iron. So do not use iron loops because they get crusted with dark crusts forming, which can particularly, I'll tell you where, if you're trying to do urine cultures or bowel fluid cultures, bronchoalveolar lavage fluid cultures, the volume that you deliver onto the agar plate will change if you do not change the loop at least once a week. It's very important. So the best is platinum, but the commonest used is nichrome. You can have deposits, as I told you, with iron on the surface, and that changes the diameter and therefore the dimensions of the loop. And also, this will directly impact the volume of the fluid which is conferred onto an agar plate. Plastic disposable loops are also available from many sources. These are examples of plastic disposable loops. There is a great deal to do with how frequently are you going to change the nichrome wire and calibration of the loop. This is something which is very important. It needs to be done. Either you change the wire once a month and you check your calibrations once in 15 days, or still better, you just keep changing your loop every week, and you depend upon the calibration done for you by the manufacturer. These are two options that we have, and there are various ways by which you could calibrate a loop using a manual methylene blue method, or you could use an automated method, or you could use a spectrophotometer to measure off the various calibrations. All sorts of things are possible. So this is just to demonstrate proper flaming of the loop, and this is what I meant by a heating device into which you just go and put your loop for a few calculated seconds, and then you take it out. Be very careful not to touch the inside of this particular instrument because it works at 700 degrees. Special instruments can be used of this, but remember, whatever you use, the whole of the wire should be heated without heating the shank. Allow the wire to cool down adequately before plating. Otherwise, what we call as a hot loop is what you will get the next day on all your culture plates. You see plenty of gram-negative bacilli and nothing grows. You get plenty of staph seen on the smear of a pus sample and nothing grows. No staph grows on culture. That's because you've gone and put a hot loop. So that's a hot loop syndrome. Very simple. These are the 4 quadrant streaks, right? And then you have a primary one, the second, the third, and the fourth. The same thing you have in the form of a plate. And this is a Klebsiella pneumoniae with the primary streak, the tertiary. And do you see the isolated colonies that one can get if you are very careful about covering almost the entire plate? But then here also there is a problem. The colonies have gone and touched the sides of the plate. That should not happen with a very good method. Now, it's very important to have isolated colonies. So therefore, when you streak, you turn the plate by 70 to 90 degrees. There are some other methods like the Z method, the compass method, and the glass rod method. Some of these, like the glass rod method, are quite obsolete, but the Z method is still used in many laboratories, particularly for urine cultures. Do not touch the sides of the culture. Beware of some organisms like Pseudomonas, like Klebsiella, as in this case it has happened, running down the entire agar plate and even touching the sides of the plate. This is a 3-quadrant plating in 3 directions. This is also done, particularly when you want to have stool cultures. This is something which you always do that. It does help when the number of organisms are not fluid culture. You go and just touch the inoculum onto the sides of the tube here and just push a bit of the sterile broth up, and the whole thing just goes down. You don't need to do anything further. You don't need to take it to the bottom of the tube and do tuck, 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 tuck. None of those is actually required. Lawn culture. Lawn culture is something which we use either by using a swab or by directly pouring this onto an agar plate. This is used for antibiotic susceptibility testing. An agar overlay method, which was part of the Erickson-Sherris method for antibiotic susceptibility testing, that is also given up now. What we normally use is the original Kirby-Bauer modification. I mean, the original Kirby-Bauer method with multiple modifications that has happened over a period of time. This is a Stokes method, wherein you have, on one side, you have the test sample, on the other side, you have the standard control. The advantage of a Stokes method is you can never do an antibiotic susceptibility without a control. Whereas the general shortcuts which laboratories take is not to use a control. That is because it takes time. It is expensive. You'll end up using so many plates every day or every week. So Stokes method is something very useful. The most important application of a Stokes method is, I'm just diverging over here and there. Please try and understand this because I can't get back to this slide once again. You see these two antibiotic discs. On one side of this, you have very good growth of the, a very good inhibition, a zone of inhibition on this side. And on this side, you have the organism. You'll never be able to pick up contaminants. You will never be able to get mixed colonies. None of these will ever be able to, it won't be made out when you have so many specimens on one single agar plate, just because you want to cut costs. This is not recommended. This slide is just to show what you should not be doing rather than to show what you should be doing. Okay, semi-quantitative cultures. This is the usual method that is followed by most of the labs for urine cultures. One straight line down, and then you move in on both the sides, the secondary cross streak, on which you get the growth of organisms, the first cross streak and the second cross streak. Whereas some of us use this way too, a primary inoculum and a secondary inoculum, and from there we cover the entire plate. So it's very important for your internal diameter of the loop to be calibrated properly. One certificate from the manufacturer, and you can't go on for 6 months to 1 year with the same loop. It's not valid. This is a Mackey's roll method. You have this is what I said that I'll try and show you, a Mackey's roll. And if you see, there is a nice zone of hemolysis around, so you know that you're dealing with either a Staphylococcus or still worse, a Streptococcus pyogenes. But this turned out to be a Staphylococcus. This is when you roll the central line tip on the agar plate, lift it up, incubate the plate as such, and the next day you see that there is a nice big set of colonies, which means the external surface of the catheter tip of the central line device is colonized with this organism. All right. Get on to the next one. I'm going to straight away deal with, it's around 3 o'clock now. I don't know how the toxicity levels are with many of you, but then what I would do is I'll try and deal with tissues. First, I'll try and deal with tissues because that's a major chunk, okay? This is bone biopsy, no, not this, I'm sorry. It was another one. Yeah. Share screen. Copyright. Where did it go? One sec. Hold on, please. Okay. Now if I share screen on this, I'm not able to get it. I don't know why. If I narrow it down to this, it still doesn't open. I don't know why. Pick up. Yes, I did. Yes, I did. That is the whole problem. I don't know why. Yeah. I got it. Yeah. I hope everybody is able to see. Okay. So this is tissues and biopsy. Now, please remember, tissues and biopsy is extremely important because this is a very valuable specimen. It just cannot be replaced. Just like you cannot replace histopathology tissues for histopathology, you also cannot replace tissues for microbiology. Almost any organ can be biopsied with the type of imaging facilities that we have these days. It does help in revealing pathogens that may have been missed previously, or pathogens from drains which were mixed with contaminating organisms. But you must have a very close liaison with the operating team. This has a lot to do with labs like ours, where we get a lot of surgical specimens, so that tests and specimen handling for various diagnoses can be planned. So we get pancreatic tissue. We sometimes get gallbladder tissue. We sometimes get tissues from the retroperitoneum, all sorts of things. And this is something which is very, very useful when the primary swabs really give you contaminants. So you can either have a needle biopsy, which is a closed procedure wherein you just take it through the skin. These are very small, fine pieces, can be missed. It may miss the infecting lesion, can get contaminated with skin flora, and can be mishandled. The second type is what you get during debridement or surgery. This is more rewarding because the volume is larger. You can really see the specimen, as you can see it over here. Less chances of contamination because it all gets directly put on into a sterile container. Maybe they might add a bit of saline and send it to you. Now, one very important thing is surgeons are very, very fond of adding formalin to anything and everything. The minute you add formalin, then there is no role for microbiology over there at all. So it needs to be impressed upon them that, yes, you take some tissue and put formalin into it for your histopathology, but then whatever comes for microbiological analysis and culture definitely needs to escape formalin. We cannot have formalin if we want organisms to grow. At the most, we can do smears from a formalinized specimen. So any cultures, any bacterial or fungal or TB cultures, formalin is a no-no. Buffered formaldehyde is a no-no. We either preferably take the tissue and put it into a sterile container with no additives, or if you have to have some additives because there is an anticipated delay in transporting the specimen, then at the most you can have a bit of normal saline or physiological saline, sterile saline pushed into it. Postmortem specimens again can be from any organ or tissue, but they are normally contaminated, but still there is a chance of isolating organisms, though it is less. But then in all cases, it is very useful. One very important thing to remember with tissue diagnosis of infections is always correlate with histopathology as and when possible. It is foolish to say, I don't speak to my pathologist. I'm always at loggerheads with the pathology guys. They show off too much. They act funny with me. Nobody acts funny with us. It's we who act funny with everybody else. So it's very important, just as you should have a dialogue with the clinical departments, you also need to have a dialogue with your pathology colleagues. After all, we were a part of pathology many years ago. We have chosen to come out of it, that's all. But then that doesn't change the pathogenesis of an infectious disease. These are the target organisms, all kinds of bacteria, fungi, mycobacteria, filamentous organisms, including Nocardia, actinomycetes, all of them can come up from a tissue. What if your cultures fail? Then, of course, you could have molecular diagnosis, which can be carried out on the homogenates of the same specimens, and that gives a better yield of target organisms. You can have all these kinds come up they make their way to our lab, and that is why we included them. Heart valves, brain biopsies, lung biopsies, liver biopsies, placental tissue. Empyema decortication tissue is a very common thing, and you get chunks of material. It becomes very, very laborious. That's one of the most laborious things. I'll just try and show you when I show you the video on this. It was an empyema decortication tissue, a small bit of it, which we took up for demonstration. You can have a very, very tiny skin biopsy. Endometrium, that is another troublesome specimen for tuberculosis cultures, because you have it's troublesome in all ways. For histopathology, endometrium is troublesome. For microbiology also, it's troublesome because you have a huge container full of endometrial tissue and you can't leave out any bit of it because you don't know which bit actually has the acid fuzz bacilli. You can have a lymph node biopsy such as this. Look at my cursor. The most important thing is to bisect this, touch the surface of a slide. That's called as an imprint smear. And then the rest of it can be touched onto agar plates. And then you could also process it in a very different way. You could also have bone along with pieces of soft tissue, pieces of osteomyelitis. It's very important. Lymph node tissues are normally sent in cases of pyrexia of unknown origin when no diagnosis can be settled, or if there is a lymphadenitis or still worse, a lymph node abscess. It's very important to provide conditions which will enhance or support the growth of all possible organisms, though this can be labor intensive and also requires very special media to be used at times. One of the commonest things that I can think of is that special medium that is used for growing Yersinia enterocolytica, which is a causative organism for mesenteric lymphadenitis. Yeah. Okay, you hold all cultures of lymph node tissue, particularly for 7 to 10 days. How many of us really do that? We chuck all cultures of tissues, left, right, and center. This happens when you just leave it to laboratory technologists without the help of an SOP to decide when to discard cultures. It's very important for that one phone call or a phone conversation from a consultant to be able to guide our technical colleagues in a proper manner. So what we do is bisect the specimen into half so that one half can still be taken for histopathology and the other half for microbiology. This is, of course, to be done in a sterile petri dish and in a laminar hood or in a biosafety cabinet. Then we cut the tissue further, take a small piece, touch the inner surface onto a slide, do a Giemsa stain because that is the stain that's going to pick up your Toxoplasma tachyzoides. And then you grind the rest of the tissue completely. So these are the target organisms in lymph nodes. A decortication empyema tissue is extremely difficult to treat or extricate organisms from the tissue. And this is, of course, obtained from surgery, which is called decortication of an loculated empyema. Long-standing empyema tissues, particularly, become very thick, fibrous, and extremely hard. It's very difficult. I mean, you are in great luck if you're able to grow an organism out of it. We normally grow Staphylococcus aureus in patients with pneumococcal pneumonia, complicated with a pleural effusion with secondary bacterial infection because of an ICD that was put inside. And then the whole thing has become an empyema thoracis. The patient was partially or wrongly treated. And then they come to the hospital with, in that particular condition, necessitating a decortication. And then you grow a Staphylococcus aureus out of such decortication empyema specimens. So what we do is inspect the entire tissue in a sterile petri dish with no additives. Please remember, no additives. You don't go and put broth into the sterile petri dish. Then you select the most purulent areas. This is something which I'll be trying and demonstrating with the help of a video. I'll reiterate the same points at that time. Select the most purulent areas of the tissue for culture, separate them with a sterile scalpel. Select some normal looking tissue along with these and collect a small portion of this in a Griffiths grinder. I don't know how many of you all have seen a Griffiths grinder. Griffiths grinder is basically a glass tube and with in the form of a pestle and a mortar assembly. You could also just walk across to a surgical stores and buy a nice big watch glass or ceramic grinder with the pestle. Homogenize the same by adding a bit of peptone water or broth to get a homogenate. So that becomes a very thick pus-like material. And from that, we inoculate a full set of media. You can even inoculate brain heart infusion broths and incubate aerobically and make serial subcultures from there, as well as smears and mounts. This is very, very useful in, it has really helped us in getting a very good growth in decortication empyema tissues. Now, this is a Griffith assembly. You look at this, this is the glass tube, and this is the pestle. And this is the pestle and this is the motor, and the whole thing just grinds. I'll show you the grinding action in the video. A sterile assembly which is made up of resistant glass, otherwise your glass can break. Huh? The tube acts as the motor with the pestle touching the bottom of the motor, which is a rough surface. And if this surface is very, very specific. If you have a surface like any other glass tube, you can't take any Felix tube and start grinding into that, a big size Felix tube, because your glass will break and the whole tissue will just fall onto the floor. So grinding of the tissues leads to a homogeneate formation. It's very important to pre-treat some of the tissues, particularly decortication empyema tissues. The other one is postmortem specimens, particularly the ones which are collected for more than 4 hours after the death of the patient. Superficial and open lesions. These are pre-treatment of these tissues. They're washed off the contaminating bacteria, and then they're subjected to the same grinding process in a Griffith's assembly. So what do? Take a tube with the tissue and take about 2 ml of peptone water, agitate it through a vortex mixture. Then you transfer it onto another container with some more peptone water, shake it once again, repeat this 6 times. So all the surface contaminating bacteria and any other mold contaminants will just get knocked off. And then you start grinding in a Griffiths grinder. It's time consuming, but then if you don't want any contaminants confusing you for reporting, then I think it's very, very important that this be done in a proper manner. Okay, now I'm going to stop here and try and play a video. Do you see this? This is the empyema decortication tissue, a small proportion. The actual tissue was a huge amount, but then this was one of the containers into which the decortication tissue had come. Yes, and this is the scalpel that is being used. We have to use 2 scalpels, or you need to have a sterile forceps on your right hand with the scalpel on the left hand. I'm a left-handed person, so therefore I hold the scalpel on the left hand, but then you could use the scalpel the other way around also. Cut it with your right hand. Here the person, my senior technologist is a right-handed person, so he cuts with the right hand. You see this purulent portion. You should be selecting out these highly purulent areas which are mixed with the tissue. You can't be taking out huge chunks all at the same time and saying that I have done through the specimen, because sometimes what happens is when you're trying to select through the specimen, you also find some hard granules. You can also find some hard bits, and those bits have to be taken out and kept separately and processed separately. All right. So this is the way by which you turn the tissue both ways and try and select various purulent areas, representative portions of these. You also take a bit of the normal tissue that will come in a very short while. There are some black hemorrhagic areas. That's probably normal tissue into which there has been a bleeding vessel that has just gone in. So that is a small portion of normal tissue along with these highly purulent pus-forming areas. You see, this is what I meant when I said you will need to have both normal as well as purulent portions of the specimen. I hope everyone is able to see these videos and the slides. Can someone confirm that they are able to see the video properly? Gautam? Just check with people. You're able to see. So that's fine. So do you see this? I'm just going to run through a little bit because I've got other things to cover as well. You see, these are even more finer portions of it. You really need to tear apart the entire decortication tissue. And if you have a nice big container of decortication tissue coming to your laboratory, just imagine the amount of time that it is going, you're going to take if you have to slice through and separate out portions after portions after portions of these tissues. You see this? Small portions from here, small portions from there. So you've got a sizable bit over here now. Now the next thing is to smash through these small bits. Now it's very important not to, when you're chopping them also, you need to be very careful because some of these bits can contain a fungus. And if you grind them completely, the fungal hyphae just break up and the fungus will not grow. You will see them on mounds, but then they will not grow. So it's very important that you be very gentle when you are slicing through tissues. You can't just sort of chop, chop, chop as if you're trying to chop meat. All right. So it's very important to be very, very gentle in your actions when you're trying to do these kind of things. Then the next thing is to take out the Griffiths assembly. This is the Griffith. It has to be pre-sterilized, and that is why it came out of a foil. So this is the special apparatus that we use. Look at the way the whole thing is transferred into it. It should not touch the top end of the Griffiths assembly. So it's very important to get the whole tissue onto your scalpel blade. You see the person is taking his own sweet time to, yes. And finally, the whole thing is inside. You push the whole tissue right into the, into the motor tube, and then you add your broth. We use brain-heart infusion broth. We don't use peptone water in our lab, but then you can use peptone water. It's just a matter of personal preference. And then now you have the grinding assembly going inside. It carries the tissue along with it. Again, you need to be gentle that you don't start grinding at that point itself. And then the bottom portion of it is what is very well suited for grinding. Do you see this? This is the grinding that happens. Everything else has to be out of the way so that, and you need to have the grinding assembly away from you so that you don't have portions of it flying onto your face. The whole thing should not spill over onto your face because all this is infectious material. Once the grinding is over, do you see the supernatant homogenate which is formed? You need to be very careful there. So this is the homogenate which is being transferred onto another sterile container. The commonest ones which we use are the sterile uricol containers from Hymedia. They are fairly good for these. And then you take loopfuls of these and explant them onto various plates. Blood agar, chocolate agar, McConkey, Cled, brain-heart infusion agar with blood, Sabarod's dextrose agar, because you want a wide range of organisms to grow. And sometimes we even have two sets of plates, one set of plates going in at 37 degrees, one set of plates which we tape and put them away without opening them for the next 3 or 4 days, because you need to open them at least after 24 hours. So one set of plates are open and the others are not. And based on what we get on initial cultures, so the whole thing is just streaked out this way. Carefully. That's the MAC. This is the whole set of plates which are being done. Once that is done, now you have the specimen, you have the homogenate and now the slides. So the same homogenate can be brought onto the slides. That will give you, we always make at least about 2 or 3 slides or smears, one for the grams, one for AFB. Please remember, it's always useful to do to screen for acid-fast bacilli and for fungus in every specimen except urine and throat swab that comes your way to the laboratory without waiting to be told to do it. That's because you'll be surprised at seeing the number of times when purulent exudates, particularly in tissues, don't give you a growth. They have a necrotic background on grams. And then finally, when you screen acid-fast bacilli, when you do a Z-Nielsen stain, they're full of acid-fast bacilli. Right. So then once this is done, this is the bit of tissue that is being taken. This is how we crush a bit of the tissue between two slides very gently, otherwise the slide itself can break. Once you've got the slide with the tissue crushed on top of it, add a drop of normal saline, or still better, 10% potassium hydroxide, so that all the stuff can be got rid of. That's potassium hydroxide 10%, followed by a cover slip, which gets onto it. Again, when you press it, you don't press it completely down, or otherwise the cover slip breaks with pieces of tissue jutting out. So it's very important to do that. And that goes straight under the microscope at low and high power for fungal hyphae. All right. Then the rest of the tissue. Now the homogenate was plated out onto a set of media. Then we have the tissue directly plated out for fungus, and just see how that is done. We don't use the homogenate because that's ground. Once you grind something, fungal hyphae can break up. So it's very important to preserve a good representative portion of your original specimen, such as tissue, to be used for fungal cultures. This is how we stab inoculate for fungus. It's very important to stab inoculate correctly and don't take it all over the plate. It's very important to push it inside the agar because the fungus grows from within. That's brain heart infusion agar with blood, 5 to 6% sheep blood added to it. That's for the most fastidious fungal pathogens. And then the rest of it, we also use a brain heart infusion agar plain. We use a brain heart infusion agar sometimes with added antibiotic. In special situations, we have a Sabarod's dextrose plain agar. In our laboratory, we generally don't use Sabarod's dextrose with antibiotics because we don't get that many skin specimens. If you get a lot of nail and hair and skin and all that, then yes, you may need to have Sabarod's dextrose with added antibiotics because you don't want contaminating bacteria growing on that or contaminating Candida growing on that. It's always useful to have a couple of Sabarod's dextrose agar plates additionally plated out because it's very difficult to go back to this tissue. It won't be as fresh as the first time. You may preserve the tissue, but then it can get contaminated at a later time. So the first time is the best time in microbiology, particularly in bacteriology and mycology cultures. It's very important to remember, look at that, a small piece of the tissue which got left out, that also needs to be taken in. It's something like how it is transferred from one scalpel blade to another and then put on back to the Sabarod's dextrose agar, SDA. And then this is the brain heart infusion broth in a tube. That's the homogenate. And the homogenate is very gently added, taking care not to the working bench. This is the BHI broth tube, which will be kept over there, and it will be subcultured periodically till we are quite certain that nothing else has grown from there. All right. So this is, I hope people were able to view this video quite well. I'll just move on to, I'm sorry. I'll just move on to a short thing on CAPD. This is definitely right. So, oops, I'm so sorry. I'll just share screen. All right. Right. So this is continuous ambulatory peritoneal dialysis, which is a very useful alternative to hemodialysis in patients with end-stage renal disease and chronic kidney disease. It's a huge advantage because our own peritoneal membrane is basically used to dialyze all the waste products from the blood. It's a closed system which consists of the commercial sterile dialysate fluid and the silastic tubing, which is connected to a Tenkov catheter. And normally you have 1 to 2 liters are infused every 6 hours. And then the rest of the stuff is collected into an effluent bag, which is an empty dialysate bag. These are just the advantages of CAPD in patients. And it's very common. Now, PD peritonitis is a very common problem when we have, it can be a very serious complication as well, necessitating huge amounts of antibiotics. Sometimes it contributes to 16% of the cases in patients who undergo peritoneal dialysis. It can occur because of a problem with any of these. The catheter, the dialysis solution, it can be a problem at this exit site over here. It can be a problem with this tubing. It can be a problem with the fluid over here or with the abdominal cavity itself. Now, where is it? The proof is basically in the effluent bag. And that is why the effluent bag is clues that you get towards treating patients with peritoneal dialysis infections. Look at this. This is a cloudy effluent. And a similar bag we will be demonstrating in the video itself. Pain is more specific as compared to the cloudy effluent. That's because cloudy effluent can be because of a chemical peritonitis. It can be because of chyle that is leaked out from a lymph, which is leaked out, giving you chylous effusion. These are some of the clinical manifestations. Patients come in with a cloudy effluent bag, abdominal pain, which is tender to palpation, with fever, nausea, vomiting, and sometimes chills. Sometimes there can be a pus discharge in extreme cases at the exit site. There can be a catheter malfunction with blockage and drainage issues. The very important thing for the diagnosis, a proper diagnosis of a CAPD peritonitis is, do you have a good quality microbiology service? How willing is your microbiology consultant and technologist to talk to their nephrology colleagues? Very often we find this is the sample that has come, this is the requisition form, and this is what I'm going to do. I mean, nobody is really bothered about what actually transpires at the end of the whole thing. So the diagnosis is made based on all of this, not just the cloudy dialysate effluent or the culture of the effluent fluid. Yeah, it's also made on the basis of a positive culture, the gram stain findings, and the symptoms of the patient in CAPD peritonitis. Differentials for a cloudy effluent. When you get a bag which is turbid, which is hazy, what are your differentials? Culture positive infectious peritonitis. It can be a culture negative infectious peritonitis. Can be a chemical peritonitis. Too much use of calcium channel blockers in patients with in chronic end-stage renal disease can give you a cloudy effluent. Eosinophilia in the peritoneum can give you a cloudy effluent. Hemoperitoneum, a ruptured vessel somewhere, can give you a cloudy effluent. Very rarely, malignancy can give you a cloudy effluent. Chylous effluent, still rare. Or a specimen taken from a dry abdomen. All these are reasons why you can get a cloudy effluent bag. It's very important to handle the bag with a forward and a backward motion. This is something which, again, you can see in the video. You inspect for turbidity, floating particles, tissue pieces, any blood or other gravel material in the fluid. Microscopy is very important because you have to know what is the kind of cellular response. Otherwise, how do you differentiate an eosinophilic peritonitis versus a usual neutrophilic peritonitis? So it's very important. Similarly, how do you look for fibrin, for blood clots, for chyle, etc. So it's very important to have a cellular response idea before we start making a diagnosis of CAPD peritonitis. It's very important to have an idea of the leukocyte number as well as the type, because many a times you can have no correlation between the WBC count and the number of bacteria in the dialysis fluid. You can have plenty of WBCs and no bacteria. Then you go looking for other organisms like acid-fast bacilli or mycobacteria, like non-tuberculous mycobacteria, nocardia, candida, even filamentous fungi, and so on. But then please remember, you're doing a gram stain with this proper knowledge that the sensitivity of the gram stain is less than 50% in the best of hands and in the best of centers. So so eosinophils in the gram stain, is it feasible? Yes, it is definitely feasible. More than 10 to the power of 6 eosinophils per liter correlates with an allergic reaction, eosinophilic peritonitis. Fungal peritonitis can give you an eosinophil. Parasitic peritonitis can give you an eosinophilic response. Intraperitoneal or systemic antibiotics can sometimes leave you with, with an eosinophilic cellular response seen on the smear. So why are we obsessed with so much of culture positivity? Now, most of the labs have a problem with CAPD not growing anything. That's because most of the gram stain smears are negative, particularly even those with plenty of polys. It's very important to have an increased yield. The diagnosis of infectious peritonitis is positively established with a culture. It guides the choice of definitive and empiric therapy. That is because if you know it's a gram positive or a gram negative, or what kind of a gram negative, based on simple things like oxidase, catalase, and motility, and simple sugars, then you can guide your clinical nephrology colleagues on what empiric therapy, follow it up with definitive results on antibiotic susceptibility testing. You can also track the possible source of infection. If you get an Elizabeth Kingi or if you get a Burkholderia capacia, then you know obviously the fluid is the problem, or your catheter is a problem. If you have Enterococcus faecalis, E. coli, or a Klebsiella pneumoniae, then you know for sure that probably a peritoneum is a problem, and there is a transgression of organisms from the bowel. The speed of bacteriological diagnosis is very important to patient care. This cannot be overemphasized. So therefore, we resort to various other methods to reduce the time to positivity and enhance the yield of organisms, such as concentration methods. Normally, microbiological diagnoses are made in less than 3 days, but then you need to hasten all these, and also hasten the diagnostic yield of organisms. These are the options. You can centrifuge the specimen, spin it down, and have a direct sediment culture. You can inoculate your Bactec and Bacti-Alert and various other bottles, which are those blood culture bottles inoculated with. You can have, these are anionic surface detergents, which we use in our laboratory. And one is Triton X and the other one is Tween 80 incorporated blood agar plates. The other one, which we have found very, very useful, you don't really need to go buying these also. You can just use plain sterile distilled water. Your 10 ml ampules of sterile distilled water, just use them to lyse your fluid that pops out the polymorphs. All these act in the same way. They all burst out the polymorphs, release intrapolymorphic organisms. Why? That is because organisms causing infection will be met with by polymorphonuclear leukocytes and sometimes macrophages, which will try and engulf these organisms to destroy them by a process of an oxidative burst. But then those intracellular organisms will not grow on culture because they have to be released. So you got to enhance or promote the release of these organisms either by using any of these anionic surface detergents or by using sterile distilled water, which will, because of its osmotic instability, the polymorph just bursts and releases intrapolymorphic organisms. So still better, you can also filter the CAPD fluid. All this needs a biosafety level 2 cabinet. Very few organisms which may belong to the hazard group 3 will require containment level 3, particularly tuberculosis or fungus. Any procedure with infectious aerosols must at least be done in a biosafety cabinet class 2A. Okay. Inoculation into blood culture bottles These are basically bottles that contain resins, which will take care of any antibiotics, particularly beta-lactams that have been given to organisms. They will also help the growth of, bring out fastidious organisms, because they're going to go into an automated continuous monitoring blood culture system for aerobically at 37 degrees with added 5 to 6% CO2. The other one is, do you see this very fine hemolysis-like zone? It's not hemolysis. It's basically the RBCs of the sheep blood that have been popped out because of the addition of Triton X. So you take 2 ml of the fluid, you add about 3 to 4 drops of Triton X reagent, which should be of Sigma or Fisher grade. You allow the whole thing to incubate for 15 minutes in a tube. We do it directly on the plate, but you can also incubate it for 15 minutes in a tube at 37 degrees aerobically, and then plate it out onto the media, and you get organisms beautifully growing out on these Triton X plates. These are the list of media that we use. I'm not saying that you have to use all of these. Those who look at costs as a major factor determining what you can and cannot use in your laboratories can make your own choices. But then at a large, you should be using these: blood, McConkey, Cled chocolate, BHI agar, BHI with added 5 to 6% sheep blood, Tween 80 blood agar, and Asabrot's dextrose. And these are the organisms that we have been able to grow out of our CAPD fluids cultures, bringing our positivity rate to close to about 70%. And we've got a paper also published on this, which talks about the efficacy of various methods in enabling the growth of organisms from CAPD fluid cultures. And it went up from meager 20% to at least about more than 65%, which is a huge jump, particularly with respect to Candida, with NTMs, with Mycobacterium species, with Aspergillus, and Fusarium. Those are the other filamentous molds that we've been able to grow. Fusarium is one, Syncephalastrum was the other. All of these we've been able to grow. Cryptococcus neoformans, Nocardia species. Sometimes we even get polymicrobial infections. One very common thing which gets overlooked is cons. The other one is Corynebacterium species. When you get any GPBs or cons, the first thing is, this could be a contaminant. It may not be a contaminant in CAPD peritonitis. You get organisms of indolent or low virulence causing infections in these patients. You can also have non-sporing anaerobes, particularly the ones that come out of the bowel. So therefore, those are brought out by inoculating your blood culture bottles. And it may be a useful thing to even include anaerobic blood culture bottles in the set of blood culture bottles. Okay, now I'm going to go ahead, stop share here, and try and show you the CAPD fluid cultures. Okay. Is this the one? I hope so. No, not this. Is everyone able to see? I have not shared, so I don't think people will be able to see.
No, we can't see here. Okay.
Yeah. I'm just trying to see where and what I should do. 1 minute. How do I? The first one I did quite well. I don't know what's the problem here. 1 minute. Okay. No, I think the first time. Hold on. Yeah. Now you'll be able to see. Okay, I'll just go back a little. Right. So this is the beginning. This is your CAPD bag. All right. So you try and look at it. The first thing is always to shake it to mix the contents of the CAPD fluid. Otherwise, you're not going to get anything. All your particles will settle to the bottom and you'll be trying to do something at the top. You'll miss all your pathogens. The next thing is you got to take out fluid from the port. So when you are to take out fluid from the port, make sure that the port is not itself is not contaminated. And then you put in a huge 20 cc syringe and needle and draw out your fluid. And you got to take out many such 20 cc fluids. Close to about 100 to 150 ml needs to be taken out of your bag. So that is why do not accept any small containers with 5 ml and 2 ml of CAPD fluids that are sent from nephrology. Just say no to them. Just tell them to send the entire CAPD bag and they will ask you, why do you need so much? Just tell them, leave that to us. That is our business. You just do as you're told. We want you to send the bag, which anyway you'll be throwing off. And that is diagnostically useful to us. That's the answer you should be giving. Many nephrology, particularly your dialysis technicians, can be very nasty. They can be quite resistant to this. Oh, all these years, we've been only giving you containers. Do you see the whole thing being taken out beautifully? Right. I'll just move a bit. Do you see the number of tubes? Each of them about 15 ml, conical sterile tubes. Yeah. So this is how it is. He leaves the needle, takes out the this thing and keeps drawing out fluid, puts it onto one particular tube and then gets back for the next lot. So this is how it just goes on, all right? It's very important to make sure that each tube is screw capped, each tube which is full of the fluid is kept in a separate rack so that you don't mix up the tubes. Okay, so I'll just sort of move past all this, all right? I hope everyone is able to appreciate. So this is the the second last tube being filled, and then you have one more tube to go. And then once everything is over, then the next thing starts. You draw out some more of the fluid. Everything is done in one go. It's very important to remember that things can splash and splurt. So that is why you always try and do it in a biosafety cabinet. Right, this is a Bactec bottle from our lab. Straight it goes inside. We use 2 aerobic bottles because you can grow any number of organisms, including fungi, also into this. And then we start centrifuging these tubes. Okay. Once it gets on, 1500 RPM, 10 minutes. Knock off the supernatant into hypochlorite. Please remember all of that can be infectious. So it's very important to remember to use a disinfectant for discard. Leave behind enough fluid. Even 1 ml is good enough because you can mix up all the 1 mLs and that itself will give you a nice good vortexer at the end. You just sort of vortex the fluid which is collected from all the tubes. Each tube can be vortexed in a similar manner. All right. So now the vortexing is over. Then the next important thing will be whatever you have vortexed, everything gets added on to one tube. That is mixing of the sediments. This also needs to be done inside a biosafety cabinet and with great care, because you can introduce contamination at any point in time. This is your sterile distilled water being added to one part of the tube, to one portion of the sediment. Leave it like that. Okay. Water lysis, that's for the water lysis. Vortex it and then just leave it for some time. The water pops off the polymorphs and releases any intracellular organisms. And that gets plated on. We have, in fact, we have one set of plates from the water lysis, one set of plates from the just the sediment of it. So we have some 2-3 sets of plates. It's in fact, in our lab, we call it a skyscraper. If there is a CAP, I mean, if there is a big set of plates, we say, oh, yesterday there was a CAPD. That's why we have a skyscraper set of plates. These are just different media. All this media which I described, a blood, a chocolate, a MAC, a Tween 80, and the Triton X and the water lysis treatment. And then the last thing to happen would be the slides. We have one for grams, one for AFB. And then we also do a culture. So that was from the sediment. This is from the water lysis. Okay. So this is one of the things. I'll just touch on processing of CSF. I don't think I have a presentation on CSF, but then what I would do is I'll just touch on processing of a CSF before we call it. Okay, this is, we chose this because this is from a hydrocephalus with a ventriculitis, a ventricular tap with plenty of fluid. And we were lucky enough to get so much of fluid. Otherwise, you hardly get any amount of CSF for your thing. The first thing that you always do with the CSF is take out whatever you can, inoculate into a Bactec bottle or a Bactealert bottle, whatever bottle you have. But then a backup liquid culture, 2 liquid cultures are very important. One is the Bactec bottle and the other one is the BHI broth. You see that small thing at the back? That is the BHI broth. And then we transfer it into a conical centrifuge tube. The transferring process is very important. The way you hold the tube, the way you cap the tube, it's extremely important there. Do you see this? The cap being held by the little finger, the inside of the little finger, centrifuge at 1500 RPM for 10 minutes. Of course, if you're looking for fungus, it's 2000 RPM for 10 minutes. If you're looking for tuberculosis, then it's not the same. It is 20 minutes at 4500 RPM or more. The supernatant of the CSF can definitely be used for all your latex agglutinations. The antigens don't go anywhere. It's very important. You see the way the CSF sediment is being mixed. It's never mixed from top to bottom. That is because you don't want the CSF to go and touch the lid of the container. That's enough to spoil the whole thing and contaminate it. put all your drops in one go, and then get a loop and start plating out. The more you go dipping your loop into the CSF container, the CSF is liable for contamination. The whole CSF gets contaminated and you start growing staph. When you do a second subculture, when you try and look back at your specimen, in case you need to, you will come up with a lot of contamination. So that's the reason why we always use a pipette and a tip to drop, to put those drops of CSF onto culture plates, and then use a nichrome wire for slides. Now just see how the slides are made. For CSF, we always have a 5-layered smear. Sometimes a 3-layered smear. It depends upon how turbid or how clear the CSF is. Just see how these slides are kept on the stage of a loop warming chamber, right? Now the slide has come out of that. The first layer is dried, and then with a sterile loop, which is flamed, you take the second layer of CSF, just spread it, put it on. While the slide is drying, sterilize your loop. Once it's dried up, take the third loopful of the CSF, put it on top of the second layer. The thickness increases, thereby increasing the chances of detecting organisms on smear. A 5-layered smear is very, very important for all CSFs. That's, I think, the last layer. That is for an India ink preparation. We don't just go and put one drop of it. You always add a bit of saline to the slide first, put the India ink, mix it nicely by drawing it up and down. This is the last part of it. The first thing that he did was put it into a Bactec bottle. Now the last part of it is putting it onto a BHI broth. And the rest of it is just preserved for future use. Okay, so now I'm going to stop share. I think I've covered a fairly good amount. Is there anything else that I've missed out? Well, there is only one more thing. I think I've got about 5 minutes. I'll try and finish one processing of swab. This is something which again is very important. And I will try and share screen on this. Right. Now, a wound swab is very important. The same thing holds good for a vaginal swab, a throat swab, or any kind of swab. The most important thing is, first thing is to label your plates, keep your plates ready, keep your slides ready, keep everything ready. Because once your swab comes out, you shouldn't be touching anything here and there with your swabs. So at least have your plates ready. And then get this thing out. The most important thing is not to touch the sides or the tip. You see this roll method. Observe the rolling of the swab. One common mistake which is done by technologists and even by postgraduates is to rub the whole swab onto the plate. You never do that, because that's when you dig the plate and you lose all the material on the swab. You just roll the swab onto the plate, just transferring organisms without disturbing the cellular response. On all the plates. A properly rolled one will look like this. Right. In the meantime, while the nichrome wire is burning away, you get your slides ready. With the same swab now, you could touch your slides. It's never to be done in the reverse order. You don't do your swab on the slide first and then get onto your culture plates, because you would be picking up contaminants from the slides onto the plates. Again, even while on the slide, it is never in a rolling motion. You always, it's never in a rubbing motion. It's always a rolling of the swab onto the slide. This is very important, so that the cellularity is preserved. And then it gets on into a BHA broth. That's the last part of it, of the swab. Mix it nicely to transfer as many things as possible. Remove the cap of the swab so that only the swab remains inside. And then whatever you have rubbed onto the plates, that can be plated out by touching onto those rubbed areas. And now you get on to, you don't rub the swab directly, you always make the circle with the nichrome wire. That's important. I'll just rush through this. Okay. I leave about 10 minutes for any questions, quick questions from the audience. You can ask questions later on also about bacteriology. There is no compartmentalization over here. I've just tried to cover as many basic stuff and some of the troubleshooting specimens that come to microbiology, like tissues and biopsies, particularly decortication empyema specimens, your CSFs, wound swabs, because that's where everybody makes a mistake, and among the body fluids, CSF and CAPD catheter fluids, CAPD fluids, I mean, in a bag. Do not accept CAPD fluids that come in a small dabba. The dabba is never to be accepted. Go ask for the bag. If people ask you why, just ask them to shut up and just give you the bag. That's it. Why? Because I say so. That should be your answer. You tell them once, maybe they will grimace a bit, they'll fight with you, but then the second time they won't even ask you. They'll just give you the bag and say, here, take, prasad for you. Go do what you want, enjoy yourself, maybe have a bath with CAPD fluid, with the effluent bag. Right, any questions or has everyone gone off to sleep? I don't know. People have to tell me. What are the conference technology guys doing? I mean, can they get on to IT support or whatever and get us questions? I'm sure people have gone for a siesta.
Gautam Bashir, you have any feedback? Hello, Gautam.
Oh, Gautam has gone to sleep. Yeah, good afternoon, good morning. You weren't sleeping, you were just dozing off, is it? Snoozing away? Okay, go on. So is there any questions? Yeah,
I see.
Questions? Oh, posting. So there are questions. Lovely. Okay, great. Satish Kumar Bhakta. Any effect of hepatitis B titer because of COVID-19? With regard to what? I don't know. How to preserve COVID-19 positive patients for future serology testing? Nothing, you just sort of, I'll just answer that question. Actually, it's a serology one, but then it's okay. You just separate out serum and can keep it at -80 or -20. Aliquot it and put it at -80 or -20. It will remain. Don't put it at 2 to 8 because it will just deteriorate. How to avoid contamination of negative control and what is appropriate fogging? I've not been able to understand what that means. I think all these are serology questions. I've not even come to that. Anything else pertaining to this? Tissue and formalin, yes, you can. You can process GeneXpert on that. Tissues from blocks is a little difficult. Formalinized tissues, yes, you can do a GeneXpert, you can do smears, but then no cultures. Dr. Ranjani Ranganath, practically, clinically applicable means to reduce AMR. Why? I don't know what that means. Probably we can take this one question up at the end. That's it? Okay, wonderful. Thank you so much for your kind indulgence. I think we should move for a tea break. I definitely need a break.
Yes.
And what time do we get back? Now it is about 4:06 in the evening. So I think 4:30.
4:30, that's fine. Yeah.
4:30 will be fine.
Yeah.
So 4:30 is, yeah, 4:30 sharp will be back to talk on serology, and if time permits, maybe I'll try and show you one more video on minimum inhibitory concentrations. Yeah. All right, fine. Thanks.
Thank you, Dr. Iyer. 4:30 India time, we come back.
4:30 India time, we'll move back.
Thank you.
Bye.
Bye. Bye.
Avi, yeah.
So it is, hello, Gautam, yeah, I think post it in the chat. We'll tell Dr. Iyer.
Yeah, 2 minutes.
Yeah.
Just bear with me for 2 minutes. The medical director is here, so I'll just sort of finish with him and then come.
Sure, of course, yeah. Gautam, are we live? Okay.
Okay. Now, I'll just touch very briefly on I'll carry on with immunoassays and troubleshootings in ELISAs. That will complete the serology. And then if time permits, I'll try and do one small presentation on parasitology. Okay. Can everybody see the this thing screen?
Yes, we can see. Yeah.
Yeah, fine.
Right. Thank you. Yeah.
Now, serology has a wide range of tests that are able to detect an extensive range of substances. Actually, it's not just antigens and antibodies. There are ELISAs or there are immunoassays which can even detect the antigens of certain substances like foreign bodies and things like that. It all depends upon how well we use certain specific antibodies as reagents. And in immunoassays, there is no pre-treatment, extraction, purification, or concentration required, as antibodies are highly specific with a high affinity. So this is very important. It essentially depends upon an antigen-antibody interaction, and this can be measured or quantitated. So any immunoassay will depend upon interaction between an antigen and an antibody, so as to achieve, there is something called as a prozone, a post zone, and a zone of equivalence. The antigen and the antibody interaction has to happen in a zone of equivalence for a particular immune reaction to be detected, and then it can also be measured or estimated and quantitated. There are two types of immunoassays. You have something called as a heterogeneous immunoassay, where the bound and the free fractions of the antibodies have to be physically separated. Whereas the homogeneous immunoassays do not require this physical separation. But then there are a lot of disadvantages with homogeneous immunoassays in the form of less specificity and a lot of cross reactions, which actually hinders their application in immunoserology. And it is for this reason that heterogeneous immunoassays, that is the ELISA, which we use with washing step. I'm sure every technologist who has worked in serology and has done ELISAs always talks about a washing step between the first part and the second part. It's that washing step which physically separates out the bound and the free fractions, which actually retains the immune complexes and washes off the rest of the free fractions which are not bound, right? So that forms one of the most important differences between heterogeneous and homogeneous immunoassays. The physical separation is very important. There are two types of this. The heterogeneous immunoassays, or EIAs, enzyme immunoassays, is quite similar to radioimmunoassay principle, RIA, except that there is an enzyme activity instead of a radioactivity. So you don't measure radioactivity, you measure enzyme activity. So this is based on the fact that either the antigen or the antibody could be tagged onto an enzyme. So therefore, you have an antigen coated onto the well. So the format for this ELISA of heterogeneous ELISAs will be the antigen is coated onto the well. You add a test serum, then you add a conjugate, then you add a substrate followed by a stop solution, which gives you a color production. So it is at this time, you add a test serum or an antibody, and then there is a washing step at the end of an incubation, after which you add the conjugate, and then again there is a washing step after the second incubation, and then you add the substrate and the stop solution to get you a color production or a no color production. That's the typical nature of a heterogeneous enzyme immunoassay as compared to a homogeneous immunoassay, where the hapten is just linked with an enzyme. Hapten is basically an incomplete antigen. So this is linked with an enzyme in such a manner that the enzyme activity is altered when the hapten combines with an antibody. So you don't need any washing step over there. So it's basically the antibody which is coated onto the ELISA plate. And then you have a test sample which contains a query antigen with an enzyme labeled hapten, and then you have a substrate. So if the test sample has the antigen that combines with the antibody, it leaves the hapten free to degrade the substrate through enzyme activity, and the resultant reaction is then just straight away read off by a spectrophotometer. So we don't need any physical separation processes to be carried out in a homogeneous ELISA. If you look at the previous one, I had said that there are two wash steps. One, when you add the test serum, which is supposed to contain the antibody, and then you have a washing step followed by addition of the conjugate, which again is followed by an incubation and a washing step to remove the excess of the conjugate, which is not bound, and the substrate and then the stop solution. So if nothing is bound, it will give you no color. So therefore, it will give you a negative result. If there is a test serum contains the antibody that adds on to the antigen, then followed by the conjugate. So the whole thing forms a complex that is followed by, and this is an enzyme. So therefore, it binds on to the substrate, and then it is followed by the stop solution to stop the reaction. And that is normally sulfuric acid. And then you get a color production, which in turn gives you a positive result. So heterogeneous immunoassays for this reason are more in vogue as compared to the homogeneous immunoassays. These are the various steps when you want to develop an immunoassay. The assay methodology has to be looked at. What is the kind of reagent selection, optimizing assay conditions, and finally validating the entire protocol. There are three very important factors that come into play when you're trying to select the correct antibody or an antiserum. What is the concentration of the binding sites? How many binding sites do you have? What is the type of what is the affinity of these binding sites to the added antigen or the antibody? And finally, what is the specificity? In other terms, we are trying to see that the less the number of cross reactions that you get, the better is the specificity, and therefore that is the better selected antibody as compared to another antibody which has less specificity with more cross reactions. So how does one do all this? How does one determine all this? How do you know what is the concentration of the binding sites, the affinity, and the specificity? So you determine something called as a titer, which measures binding affinities, which actually is two dilution curves. I'm sorry about the spelling error over there. And then you do something called as a Scatchard analysis, which is nothing but ratio of the specifically bound to the free antigen plotted against the concentration of specific bound antigen. So this gives the number of binding sites and the affinity of the binding sites. And then, of course, you also go around determining cross reactions. So the concentration and the affinity, which actually goes in turn to determine the specificity of the antibody, which is going to be selected, that is done by the Scatchard analysis. Okay, now the target concentration of the analyte, which is to be used, that determines the assay which is going to be used. If the analyte size is very small, then you could use an immunoassay. An immunometric assay is normally used for larger analytes. Still, larger analytes are much better used or much better detected using an agglutination or a precipitation method. That's when you get an agglutinate or you get a floccule. That is the basis of a VDRL, a Vidal, a Brussels standard agglutination, a Weyl-Felix reaction, or for that matter, any of the hemagglutination reactions that we use, where you can see the whole reaction happening with the naked eye. Whereas, I mean, if you have immunoassays like ELISAs, you can't see it with the naked eye. You need a spectrophotometer to tell you whether it is a positive result, a negative result, a color is developed, not developed, or some color is developed. And that is when you call it a gray zone reactor. All right. How do you, now when you select an antibody, this is the K value, the equilibrium constant. Any antibody with a high K value will have a high sensitivity, specificity with very little or no cross reactions. You can have two types of antibodies, monoclonal and polyclonal antibodies. They differ basically on monoclonal antibodies reacting with one epitope, polyclonal antibodies which react with many epitopes. Now, this is the solid phase. Solid phase is basically the plate that you use. Okay, the plate which comes in our ELISA kit. We always take out one plate, and then so sometimes it depends upon whether you're going to use the whole plate or whether you take out one strip to do an ELISA. So the solid phase basically permits the separation of reacted from unreacted compounds during the test. So this is essential that the solid phase should be able to take up an adequate amount of the reactant in a reproducible manner. That is because the solid phase is the one which is coated with either the antigen or the antibody. Now onto this, you're going to add on the test sample. Now, whatever is there in the test sample, if the antibody is coated onto the plate, then the antigen which is present in the test sample should be able to bind to the antibody on the test plate. So that ability should be there for this solid phase. Earlier on, they started using things like cellulose, polyacrylamide, cross-linked dextrans, rubber, silicone, and plastics. But the major disadvantage is that there is a washing step in which all these need centrifugation. Whereas nowadays, the present day microtiter ELISA plates are all made up of polystyrene. They're very easy to use. There is an adequate reproducibility of uptake of most of the antigens. Polyvinyl plates are generally not preferred because they give a lot of interference, background interference, which is also called noise, and that can interfere with your ELISA readings. So therefore, it's not recommended for visually read plates. Polystyrene, some polyvinyl plates can be used on an ELISA reader with very minimal amount of background interference. How do you coat these ELISA plates? Under optimal conditions, the way that you coat an ELISA plate will be determined on how much time will you take, the temperature, the pH, and the concentration of the thing that you're going to coat onto the plate, the reactant. So this concentration, and how do you come to assess all this? That is done by checkerboard titrations using reference reagents. All right. And then the efficacy is tested with reference sera and reference conjugates, because this is very important, where the antigen is coated, because many antigens are crude extracts and non-specific reactions can occur with control sera. Hence, control antigen extracts from uninfected animals or uninfected tissue extracts are very necessary as quality control in each run. So this is the basis of determining your positive and negative controls. All right. So, you just sort of don't take any crude antigen, because that will be a mixture of many such epitopes. And that is what gives you non-specific reactions. Whereas we take monoclonal antibodies or very, very specific epitopes, an antigen which has got one single epitope or max 2 epitopes, so that a monoclonal antibody can come and just attach onto it. So that is what is used to coat the ELISA plate. What are the factors that come into play when you select a conjugate? What is a conjugate? These are basically enzymes that are labeled on or tagged with anti-human globulins. The properties of an ideal conjugate: they should be stable. If they are unstable, then the whole thing just breaks up even while they are in solution. They should be highly reactive, because they must be able to come and attach themselves to an antigen-antibody complex. They should be available in a pure form. You can't be having an impure form, because you will have cross reactions. They should be cheap and safe to use. Otherwise, that increases the cost of your ELISA microtiter systems that are available. And finally, they must lend themselves to a convenient detector system. The most commonly used enzyme labels are horseradish peroxidase or HRP conjugate and alkaline phosphatase. Out of these, most of the ELISA plates which you see will have HRP conjugates as the favorite, because it is cheap, it is easily conjugated, and it has a wide variety of substrates. Now, the enzyme activity. The definition is based on the rate of conversion of the substrate. The units so assigned depend on the test conditions to be designed. The concentration of the enzyme is adjusted so that as the product is being formed, there is no gross alteration in the concentration of the substrate. The rate of formation of the chromophore is measured by this law, which is called the Beer-Lambert law. A is the absorbance, E is the extinction coefficient, and C is the concentration in the light path. So this entire enzyme activity is how fast or how slowly or how well it can convert the substrate. The main purpose of the substrate is to provide a good sensitive detection for enzyme in the conjugate. All right. So E plus S is the usual reaction that you're trying to look at, the enzyme substrate complex that is formed. The properties of an ideal substrate: they should be chromogenic, initially colorless and later give a color on degradation. They should give completely soluble products with a high extinction coefficient. They should be cheap, easy to use, and safe. The commonly used substrates are para-nitrophenyl phosphate, diaminobenzidine, 3-orthophenyl diamine, that is 3-OPD, the best substrate for peroxidase. It is completely soluble with a very high extinction coefficient. And the OPD is the usual substrate that is used. It's photosensitive. So therefore, great care must be taken. You don't sort of keep it out, particularly if there is sunlight in a room. It's very important that you don't expose some of these substrates to light and to sunlight. It is not carcinogenic, though it has been reported to be mutagenic. So OPD is the usual favorite among the substrates, but then there are some no-nos to be observed, some caution to be observed while using an OPD substrate. And then, of course, you can do a visual reading, but then this is not very specific, except for some of the antigen detection systems like a rotantigen or a Clostridioides difficile antigen, where a gross yellow color can easily be made out by naked eye. Most of the other ELISAs would depend upon a spectrophotometric reading, and this is more accurate with a greater precision. So that's why almost all our ELISAs are always done with a spectrophotometric reading. One very important caution that I would add to saying spectrophotometric reading is, do not transcribe onto a notebook. Your readings must be recorded, and they must be printed out on paper directly with no transcription. If you transcribe, the minute you start writing down readings just to save on printing paper, thermocol paper, it opens up new vistas for making mistakes. You can have transcription errors of 0.010 being put as 1.00, right? So these kind of problems where you put the decimals this side and that side can make a huge difference to the final qualitative result that you give to an ELISA of a test parameter. So it's very important to bear this in mind when we try and read results. What is a cutoff? The cutoff is something that is devised by the kit manufacturer using a method of calculation that would clearly discriminate between positive and negative results. This cutoff value is calculated by multiplying the mean and the negative absorbance values by a factor. That factor is known only to the kit manufacturer, and they determine this factor after a lot of experimental work, which is done using standard controls or commercial controls or internationally accepted controls by IFCC, International Federation of Clinical Chemistry. The results could either be a positive result, wherein the result of the test sample is well above the cutoff or the absorbance. This is determined by testing a large number of negative samples and the threshold being considered as the upper limit of the negative sample values. Whereas if the test result is well below the cutoff value or the absorbance, then obviously it becomes a negative result, right? And then you have a cutoff value or an absorbance, which is used, anything which goes above the cutoff value and below the cutoff value, all right? That is what will give you a positive and a negative result, respectively. So the types of cutoff values, an absorbance value, which is the direct measure of the sample's reactivity, or you can have a cutoff value wherein the absorbance of the sample is compared to a mean of a group of known negative samples, or the third one is a unit. The sample of known content is tested along with the test samples, and a standard curve is constructed so that the absorbance of the unknown values may be calculated from the curve. This is what you do for an anti-HPS in t-test as a unit, where you need 319, 102, 17, 22. So how do you get all that? By using various standards of known content, of known values. And then you plot a curve, that is your standard curve. From there, you drop down the value which you get as an absorbance value for the sample, that is dropped down from the standard curve, and that gives you an estimate of the antibody t-test, typical for anti-hepatitis B surface antigen antibody titers. It can be used for various other antibody IgG titers of rubella, of toxoplasma, of cytomegalovirus, of herpes simplex, and so on, when you want to quantitate the IgG antibody, particularly for rubella and for measles and mumps and things like that, when you want to quantitate the antibody which is present in the patient. Okay, now I'm going to stop over here, get on to another presentation, which would deal with an okay. Now, the second presentation which I have will also deal with some quality assurance processes of ELISA. Right. So QA and QC in ELISA. Now, what is the difference between quality assurance and quality control? This is something which all the time comes to anybody's mind, because we keep using these two terms very interchangeably. They are not interchangeable. Quality control is very different from overall quality assurance. I'll just tell you what exactly it means. Whether you have quality control or quality assurance in laboratory medicine, it's almost like salt in our diet. Now, this is a very common thing that I keep using in all my lectures. You have lunch prepared. All of you all had lunch, okay? And all of you all are going to go home and have dinner. Suppose if you, what do you expect in your lunch and in your dinner? You expect some good food with a lot of masala, with some oil, some boiled vegetables, some salads and stuff like that. But then suppose if all of this is served with all the masalas and oil and ghee and everything in the world, but then your people in the kitchen forgot to put salt. Will it be tasteful? It's going to be absolutely tasteless. Quality assurance is something like that. You do everything possible in the laboratory to issue a very good report, but then there is no quality. There's no quality assurance. You don't use controls. You use controls, don't document them. Your controls are failing, nobody is bothered. So it's something like that. Nobody notices salt in the diet. Do you say, wow, the salt is wonderful in the food? No. We always say there's more masala, there is no masala, the masala is absolutely perfect. It's spicy, it is salt, it is spicy, it's bitter. All kinds of things are used. But then do we say that wonderful, the salt has been put wonderfully? Nobody notices salt when it is present in the diet. Similarly, nobody notices good quality assurance and good quality control in laboratories when it is present. It's taken for granted. It is like, it has to be there. Ye to hona hi chahiye, right? It's taken for granted. But then it's impossible to ignore when it is less or when it is absent. You have sambar or dal or something served to you with less salt or no salt. Can you eat that? You can't. The same way, a report cannot be stomached from a laboratory with no quality assurance. When somebody knows that these values are wrong, suddenly a person who actually is polycythemic and you give him a report of 8 grams hemoglobin, is that going to be tangible with reality? No. That fellow is going to come back fighting with the laboratory, right? So it's very important to differentiate quality assurance from quality control, because this makes or breaks a laboratory. The terms are used interchangeably, but actually they are not synonymous. Quality control, this actually gives an idea of the state of the process in progress. When you use a positive control, it says whether the positive control, the known reagent which has been used as a positive control should be positive. A reagent which is known to be negative should be negative. So it gives an idea whether the test process in progress is correct. Do we continue to use this particular kit, or should we stop and review and don't issue results to the patient? Examples: a reagent QC, a positive control QC, a negative control QC, controls which are used in the assay, and sequentially performance of various reagents and controls that are used sequentially. On the other hand, what is quality assurance? How does that differ from quality control? It is used interchangeably, but the two terms are not synonymous. To do with a particular test. It starts right from the time you collect a sample from a patient to the time the report goes back to the patient. That is overall quality assurance. If the person who collects a sample doesn't know he does so many venipunctures, he does a counterpuncture, he leaves the patient with a hematoma, that is bad quality assurance. That has got something to do with the person who collects the sample. The sample is collected, it is left on the ward table for 4 hours and does not come to the laboratory, and it's a ammonia or it's serum electrolytes. Do you think after 4 hours, if you give serum electrolytes, it's got any meaning? No, it doesn't, because all those electrolyte values, all the sodium and potassium values have changed. So it is of no use. Again, a bad example of quality of, an example of bad quality assurance. So it's got nothing to do with one particular test. It basically tests a complete range of processes that go from the collection of a sample to the time a test report is given out to the patient. So it encompasses a wide range of activities in the laboratory medicine. It talks of consistency and accuracy over a period of time, not just one single test at a particular time, over a period of time. Look at the difference in the way that these terms are used. Look at the way the descriptions are used. Analysis and trends. You don't get analysis and trends only by using quality control for one particular ELISA or one particular test. Whereas quality assurance is analysis of how your quality control samples have fared over a period of time. How is your negative control fared over a period of time? How is your borderline control serum fared over a month? That is quality assurance. It is a trend that you talk about. You manage various levels of performance. For example, record reviews, trends and shifts in the ELISA, and all of this can be used as and this is what you find in a Levy-Jennings curve. There is a third term called quality assessment. You have put up a quality management system in the laboratory. Now, what exactly, how do you know that your QMS, your quality management system, is working in the laboratory? Is quality in place in the laboratory? That is determined by quality assessment. It's a means to determine the efficacy of the whole process of quality management. Is the quality in place in the laboratory? Can the patient and the laboratory personnel rely on what results emanate from that laboratory? So it involves a check on not just one single quality control, test and procedures that actually have been selected. Is there a problem in test selection itself, in the methodology selection itself? Personnel management and competency testing of laboratory personnel, equipment performance, records, reproducibility of test results. So if you see, quality assessment starts right from 5.1 to 5.10 in our NABL ISO 15189-2012. Those who are dealing with this, just go back and check. It deals with everything from 5.1 to 5.10. Quality management. These are two terms. You say quality management, quality assessment. Quality management is what? Interrelated processes between the patients and the management. The role of the management and its commitment to quality. Human resources management. How well are you managing your human resources, your technologists, your personnel who are available in the laboratory? What kind of quality planning is being done? So it has the concept of, quality percolated down to the last man in the department and the hospital laboratory. Then the next term is quality improvement. Previous sections lead to this quality improvement with higher levels of performance in the laboratory. It's based on results of the internal audit, patient needs, changes in methods, kits, reagents, and solutions, and so on. Now, these are some of the principles and formats of an ELISA that I can talk to you about. You have an indirect sandwich ELISA, a competitive ELISA, a capture assay. Basic requirements of these, you have wells, microtiter plates, right? And a solid matrix face onto which you attach certain antigen or an antibody. Then you use a conjugate, which is an immunoglobulin, which is coated with, which is bound to an enzyme system. The commonest being used is an horseradish peroxidase or an alkaline phosphatase. If you have an enzyme, you also need a substrate for detection. So therefore, an OPD substrate. Now, this is antigens are attached to the solid phase. All right. These are the antigens on the solid phase. Then you add the test serum, which is supposed to contain, if you're, so this is an example of HIV. So the antibody in the specimen comes and binds to this antigen, which is on the solid phase. Once you finish with this incubation, you incubate, you have to give some time for the antigen antibody to occur. That is the 1 hour which you put your ELISA plates inside the incubator. Once that is over, you want all the unbound antibody to be out of this whole thing. So therefore, you wash, because this is a heterogeneous ELISA. It's an heterogeneous enzyme immunoassay system, wherein you got to physically separate bound and free portions or components of your assay. Then you put the enzyme conjugated anti-human immunoglobulin. This, if the complex is formed, this will come and bind to it, otherwise it will not bind. So again, you've got to give some time for this conjugate to come and bind to it. That is the 1 hour for which the plates again go inside. Then there is a washing step once again. Once the washing step is over, all the unbound conjugate will move away, leaving behind only the bound conjugate. And then you have the substrate, which will react with the enzyme to form an E plus S. So you have a substrate with the enzyme conjugate, which is bound to the antibody, which is bound to the antigen. So this whole thing forms a complex. And then you put a stop solution to stop the reaction, and then read this off in a spectrophotometer, which is your ELISA reader. So this is what is written over here. Antibodies in the serum sample bind to the antigens on the face, detected by the enzyme labeled IG conjugate with the help of a specific substrate system that reacts with the enzyme. And then you get a color reaction, which is directly proportional to the concentration of antibodies in the serum sample. So if the color reaction is dense, if the absorbance value that is read off on a spectrophotometer or an ELISA reader is high, the higher the value, the greater is the concentration of the antibody. Why? Because the concentration of antibodies in the serum sample is directly proportional to the color reaction, therefore directly proportional to the absorbance value that you get off a spectrophotometer. I hope everyone is okay with this. Yes? Any questions on this? I'll be prepared to answer this at the end of the session. This is the most common ELISA format, which is called a sandwich ELISA, because you're sandwiching the antibody to be detected between the conjugate and the antigen on the solid phase with the help of a substrate. So this is your sandwich ELISA. Okay, I'm going to skip this because I've already said this. All right. Now this is a capture assay. This is how you would do a dengue IgM assay or a dengue IgG assay. Here, what you do is a monoclonal antibody. Again, they've just taken the example of HIV. So this is a monoclonal antibody to HIV is tagged onto the solid phase, is coated onto your solid phase. All right. Now this monoclonal antibody will combine with the antigen, HIV antigen, which is there in the reagent. You add the HIV antigen to this. Then you add the patient antibody in the specimen. You're basically looking for patient antibodies. Now, patient antibody cannot come and react with the antibody, right? You cannot have an antibody. So therefore, you have an antigen in between getting sandwiched. So this is an extra reagent that is added, wherein the HIV antigen comes and reacts with the monoclonal antibody. Now this antigen epitopes are free for the patient antibody, which is present in the serum sample, that will come and get added or not added. If it is not added, then there will be no immune complex formed. When the antibody gets added onto the antigen, then you get an immune complex over here. Then you wash at all these steps, and then you add the conjugate where you have an enzyme that is tagged on to a substrate where you get an E plus S complex. So now you have a substrate and enzyme conjugate with the antibody present in the patient's serum sample, with the antigen which was present in a reagent that was added to the solid phase that was coated with a monoclonal antibody initially. So this whole thing forms a complex. Now this is read off on a spectrophotometer or an ELISA reader. Again, if you look at this, this is what it is. An antibody to this original antibody. That's what I mean by saying anti-antibody. So this is an anti-antibody which is added onto it. So this can be an anti-IgM when it is called as a MAC ELISA or a mu chain capture ELISA. It can be an anti-antibody to a IgG when it is called as a GAC ELISA, which is a gamma chain antibody reaction ELISA. So the antibodies in the serum get attached to this anti-antibody with the enzyme labeled antigen added. So therefore, this is the complex initially that is formed. Then you add the substrate. This whole thing suffers in sensitivity. Any capture assay will suffer in sensitivity, but this whole thing once formed, it's pakka positive. So which means it has got a very high specificity. Low concentrations of antigens and antibodies are also detected, but then there is some amount of sacrifice on the sensitivity. Specific classes of antibodies can be detected, as I told you, an IgM or an IgG. Now, this is a competitive assay. Competitive assay is where the serum sample antibody competes with a known, another antibody. So here, what is coated onto the ELISA plate is an antigen. Then antibodies are attached to the immunoglobulin complex, bind or do not bind to the antigen. The patient's serum antibodies compete with the conjugate antibody. So the conjugate gets added first, followed by the patient's serum sample, and then you have a substrate. Now here what happens is no color indicates a positive reaction, just the opposite of a sandwich assay. Color reaction indicates a negative result. It is less time consuming than a sandwich assay. It comes out, you can get results in about an hour and a half. There is no pre-dilution of the patient's serum sample that is required. Now these were the types of ELISAs. Then there is another entity called generations of ELISAs. A first generation of ELISA was highly sensitive, but very, very non-specific, with a lot of false positive and cross reactions that happened. That is because whole cell viral lysates were used along with the cellular components which could add to the false. Then the second and the third generation ELISAs added to the specificity, retaining the sensitivity of the assay. This is where you had recombinant technology in the second generation assay, and you had monoclonal antibodies being formed in the third generation assay. So therefore, the specificity increases while retaining the sensitivity of the assay with very few false negative results. So in the first generation, we used whole viral lysates, recombinant antigens in bacteria, viruses, and fungi. This formed the basis of the second generation assays. And then now we have chemically synthetic peptides, which are nothing but monoclonal antibodies or monoclonal antigens, which are used in the third generation assays. Now, in most of the ELISA sheets, you will find something called as a blank. This is coated with antibody or the antigen. There is no serum added, no other reagents are added. It is just left like that. They control for any plate contribution to the OD value. Like suppose you have a plate from which you take out an ELISA strip. How do you know that the ELISA strip itself is not giving you a positive result? That information comes by using a blank in the ELISA. So that is why it's so very important. Now generally what laboratories do is to save up on one particular well, you don't blank an ELISA at all. But then it's very important to know what is the contribution? How does your ELISA strip react on a spectrophotometer? That can be, that information can be obtained only by using a blank in the ELISA from the OD value. So low values approaching 0 is what you expect. If you get 1 point something in the blank itself, then that means there is a problem in your ELISA strip and the whole kit has to be returned back to the manufacturer. Or there can be a plate wash problem, a substrate problem. There are many other problems, technical problems, which can come up if you get a very high blank. So quality control is basically, is this test working correctly? Each run must include one full set of controls. The controls for each test run must yield results within the limits of the manufacturer's criteria for acceptability and validity of the run. Now, what do I mean by this? A positive control, it's, if you look at the kit manufacturer instructions, it will tell you that the positive control must be between 1.1 and 1.9, or it must be between 1.1 and 2.9. So the absorbance value positive control should come within this range. If it doesn't come, then there is a problem. Similarly, a negative control also should be within manufacturer's set instruction criteria that is given in the kit insert. All test kits must be used before expiration date to ensure valid results. Physical parameters of the test, such as incubation time and temperature, must be followed to ensure a proper performance. Internal controls for each kit is of paramount importance, and sometimes to obviate any lot-to-lot variation, or at least to know what is the lot-to-lot variation, you do use external controls. All right. Now, the quality control program is so very important in serology. That's why I thought I would pick up quality control program in serology rather than in bacteriology. There also an internal QC program is very, very important. If time permits, I'll get on to it. Otherwise, I'm sorry, I may have to stop when at the end of this presentation. Largely, it's an internal quality control program for every test in serology performed by the laboratory. It needs to be documented as a full SOP in the laboratory, must be assumed, understood by all technical staff, and it is designed basically to verify and reliability of the test. Controls which are used in the ELISA. Why do we use controls in an ELISA? They are required to validate the results in the assay. They must be treated in the same manner as an unknown sample. You don't give special treatment to them. You cannot dilute a positive control and say, I will use it for many, many more days. That cannot be done. Controls must be included in every run of the ELISA. The values obtained on day one cannot be used for subsequent runs. This is another problem with many laboratories, where on the first day when you open the kit, you use a positive control and a negative control and a cutoff control. And then you use that same cutoff, the same negative control value in subsequent runs for calculations, and you save it, and you feel that you're saving up on runs, on the wells. But then it's very bad practice and very poor quality assurance to be doing something like this. They are used simultaneously and under the same conditions as you would do a sample. On completing the test, the absorbance values of the controls must be examined first, and calculations for validity of the assay done initially. That means when you're using a positive control and a negative control, the first thing when you get the printout of the ELISA sheet is to know whether your positive control is functioning properly, your negative control is functioning properly, your cutoff calibrator or control, if there is one, then all those need to be checked before you get onto the patient test samples. The results of the test are accepted and valid only when the controls used in the assay are valid and they have passed the validity criteria given by the manufacturer. These are the types of controls. You can have internal controls which are labeled as positive and negative controls. They're treated in the same manner as samples, used with the same lot number of the kit. Now, if you have one kit, you cannot save up your controls to be used with another kit of the same type or of another type. You can't be doing that. and expect all the controls to function properly and all the sample reactions to be the same. Expected range of values are obtained with internal controls. External controls are those which are used to monitor consistency and a lot-to-lot variation. They're obtained from pooled test kit controls. Borderline controls are the most important type of external controls. I'll just come to that, what is meant by a borderline control and how it is done. It indicates borderline controls are the most important because they indicate very minor changes, especially those which are just around the cutoff value. It affects ELISA results, particularly when you have a borderline or a gray zone result. They're time consuming and labor intensive to establish borderline controls, but then it's very, very important because they indicate potential problems and inaccuracy in an ELISA serology. Now, these are some of the sources of external controls for an ELISA. National reference laboratories, you can have them commercially available. They're commercially available, but they're expensive. You can produce them in-house, but they're very tedious and laborious. You can collect external control samples from another clinical laboratory, but they have to be very, very well characterized before you can apply them. You can have pooled test kit controls, ideal and economical, but then they must give the same values as what is intended. Freeze-dried controls are acceptable, except for borderline control samples because the antibody activity is generally lost on freeze-dried. Are run. This is just to show you how these look like. So we blank, there is a positive control, oh God, there is a negative control, and then the samples follow this. And then at the end, you use a borderline control. That is what we do in our laboratory. This is for an HIV total, hepatitis A virus total antibody. So for every single ELISA, we have something called as a borderline control, which is made. And we say over 20 runs, this is the mean, this is the standard deviation, and then the CV percentage and the measurement of uncertainty is worked out based on the borderline control and not on the positive or the negative control. The borderline control is so important because it detects minor variations and small mistakes or errors in the ELISA. It's important not to generate false results for test samples with an OD near the cutoff. So this is borderline controls in an ELISA. It's recommended to have more than one borderline control in each ELISA run, but then at least one borderline control. Consider a borderline control as invalid. A run should be invalid if both the borderline controls are beyond the 2 SD limit, if one of the controls is beyond the 3 SD limit, and if it exceeds the standard deviations in 2 consecutive runs. How do you prepare a borderline control serum? Right, so you select a high titer serum or a plasma. All right, you can also pool a number of positive seras and then run an ELISA and see what is the absorbance value that you're getting. Many such sera, one serum sample could give you 0.9. So say for instance, if you're talking about a borderline control for HIV or HCV, the control value may be your absorbance value for one particular sample may be 0.9. The next one will be 1.2. The third one will be 2.1. The fourth one will be 4.1 and so on. You pool in all these things and run one ELISA with that pooled serum sample. You see what is the amount that you're getting. So you select such a high titer serum or a plasma sample. Now you serially dilute this high titer serum or plasma with normal human serum. This must be totally non-infected, and you may require lots of human serum to dilute this. Select a suitable sample dilution to achieve the desired titer. That means it should be plus or minus 10% of the cutoff. So if your cutoff is 0.9, calculate plus or minus 10%, and your borderline control serum should give you an absorbance value which is within plus or minus 10% of that 0.9. I hope everyone is with me on this. Now you prepare a batch bulk of this borderline control sample. After that, you validate this. Now, once in one run, it may give you a beautiful value. But then if you store this in batch and then try and run it over subsequent days, it may fail. So therefore, you validate it over 20 consecutive runs with the positive control, with the negative control, and with 3 lot numbers before accepting it as a borderline control. These are the criteria that one uses before you say, I have prepared a borderline control serum. Then you dispense and store this particular serum at -20. Validate after storage. That means every time you take out one aliquot, you run it, it is functioning properly, and then you start using it. Intra-run reproducibility. Now, what is meant by, now these are some of the technical terms that are used in quality assurance. What do you mean by intra-run reproducibility? Intra-run reproducibility is where you have, do you see this SS 296, 296, 296, and then you have a 298 and a 300. Similarly, you would be having so this is an intra-run reproducibility. So you have 2.80, you have 2.9, you have 3.057, and you have, and then immediately after that, you have a 2.98. Now, intra-run reproducibility is when you show the reproducibility between wells within a single ELISA run. This actually tells you what is the manual dexterity. It is a clue to the manual dexterity of your operator or your technologist. How well is their control over their pipetting? They could be placed in adjacent wells or they could be spaced out over the plate. Now here there were only 2 samples, so therefore we have put intra-run reproducibility just like this. Whereas, if you had something like 20 samples, I would put one SS296 here, I would put the second one somewhere here, I would put the third one somewhere here. Then the absorbance values of all the samples are calculated. And then the difference between this and this should be less than 10%. The difference between this and this should be less than 10%. So the difference between 2 consecutive readings must be less than 10%. And inter-run reproducibility is where it is a measure of consistency between kits and at different times. So you use one borderline control, or you use one particular sample or a control value, and you put it in different kits, or you put, if you open one kit and you're doing 20 runs, you put it in run 1, run 3, run 5, run 7, and then look at what was the absorbance value where in run 1, in run 3, in run 5, and run 7. Again, that difference should not be more than 10%. The lesser the difference, the better is the inter-run reproducibility and therefore the predictability of the results. So these are very important. Intra-run is where within one single run, you're trying to put the same sample 3 times or 2 times or 4 times or whatever. Inter-run reproducibility is when you're trying to put the same sample at 2 different times in 2 different assay runs or 3 different assay runs or between 2 different kits of the same batch. Then you calculate something called as an E ratio. So this is the relative reactivity of a given test sample in relation to the cutoff value in a run is what is called as an E ratio. This will take care of variations noted with internal controls in the kits from the same manufacturer and from the same lot numbers of kits. This is an E ratio, the sample OD to the cutoff OD. All right. This is the mean and the standard deviation. Mean is nothing but you just take 20 runs, absorbance values, and then you calculate a mean. From there, you get the formula for calculating the standard deviation. Once you get the standard deviation, this is the measure of the variation of observations above the mean and defines the expected range of a control in relation to the mean value. That means how much variation in observations do you get revolving around the mean value. That is your standard deviation. All right. This is just to give you an example of how to calculate a mean. Standard deviation is just a statistical thing that quantifies how close numerical values or QC values are in relation to each other. So you have precision and accuracy, right? This is how accurate all of them go and hit the target. This is accuracy, whereas you can have high precision. And you can have a good precision and good accuracy, poor precision, where all these things have just strewn across the entire target. None of them have come. All these values, 1, 2, 3, 4, 5, 6, 7, 8. There are 8 of these. This is an example of very good accuracy and high precision. This is where there is very poor precision. Accuracy may be fine. You may have aimed it to go over here. It has gone over there, but then the precision is very bad. So it provides the laboratory an estimate of test consistency at specific concentrations. So you calculate the standard deviation, then you plot a Levy-Jennings chart, which is a graphical representation for successive run-to-run or day-to-day quality control. This is created for each test and each level of control, and this is how it looks. You join all these dots and you will get a graph. All right, I'll just give you some examples of graphs. Look at this. This is your mean. And then those are the points which have been joined together to give you this. This is your -1 SD. This is your +1 standard deviation. -2 standard deviation, +2 standard deviation. All right. So it is not even touching the -1 or the +1 standard deviation. So therefore, this is an example of a very good quality control. On the other hand, just look at this. This is something which we had as a problem. Look at the zigzag arrangement, and something has crossed the -2 standard deviation twice. If it crosses once, you say this could be at random. Something happened on that one particular day, but otherwise we are perfectly okay. We are not perfectly okay because it has happened 2 times. This could be a systematic error. All right. So therefore, we calculate something called as a CV percentage. A CV percentage is nothing but a numerical value which describes what is the level of variability within a set of readings independent of individual observations. So if the absolute values are closely similar, then it is wonderful. If the absolute individual values are different, then the CV percentage would be a much better measure of this particular value. So it gives you coefficient of variation is the CV. Standard deviation is your sigma by the mean. So standard deviation by the mean gives you an idea of how precise the laboratory results in a particular lab would be. That is why NABL asks you for CV percentage and an MU. Inconsistency among individuals. Now, what does the CV percentage actually convey in an ELISA? Individual readings in an ELISA, what is the inconsistency? It reflects the level of performance of the lab for a particular assay. Inter-assay CV percentage is a better measure for the precision of the ELISA. So if the CV percentage is very high, you get laboratories reporting a CV percentage for HCV at 20, 25, 35, and so on. These are the reasons. Splashing outside the wells, inaccurate pipetting technique, drying out of the wells, inconsistent sample handling, calibration errors, incorrect filters, all sorts of things. The software of the ELISA reader, the ELISA reader is not being calibrated. So it basically reflects overall poor quality assurance in the laboratory. Now this is serial number, your OD values, the cutoffs, the E ratio, the mean, the standard deviation, and then from the standard deviation, you can calculate your CV percentage, and CV percentage multiplied by 1.96 gives you your measurement of uncertainty. All right. Now, when you plot this as a graph, it gives you shifts and trends. This is very important in a Levy-Jennings chart. So, it tells you whether it's going over like this. These charts must actually be viewed at least on a weekly basis, if not on a 3-day basis. And then when you do that, it gives you a trend as to how your things, if you join all these dots, you would get a very good trend which moves up like this. Suddenly there is a movement here. Do you see this? That all the dots are on the same side of the mean. All the dots here are on the same side of the mean. It basically tells you deterioration of the reagents, a routinely used pipette is slowly losing its calibration. Look at this. Control values of 6 consecutive things are on the same side, or they are all falling on one side of the mean. So here, probably your pipette calibration is at stake. Or the second thing was deterioration of reagents. So this is one of the major important things that a shift, a trend in quality assurance tells you. It indicates a major change in the test performance. Switching, if there is a major change in the test performance, you've probably switched on to a new lot of kits, new reagents have been purchased, or the incubator temperature has not been controlled, or your pipettes have not been changed. You should be changing, or a new technician has walked into the laboratory. Now, all the while I kept saying borderline result, borderline result. What is meant, that is also called as a gray zone reactor. This is a slightly elevated OD, which is just above the cutoff. It suggests a very low antibody activity. It's also called borderline reactive samples. For HIV, now this gray zone reactor was described way back in the 1990s when HIV ELISAs came into being, and they said that the reasons for a gray zone reactor can be early seroconversion, very low antibody activity in the serum. That is the reason why you are getting a very low absorbance value, or it could be a false positive results. It's very important either way that anything which is borderline or a gray zone reacting sample must be repeated. Repeatedly, borderline reactive samples are then tested and confirmed with another method such as a PCR. So when we have a borderline reactive result for HIV or HCV, we always say that this is borderline reactive, add the comment for it, and then say, kindly retest and confirm the status of this patient with an RNA reverse transcriptase PCR. And how much should this cutoff value be to call it a borderline reactive? Plus or minus 10% of the cutoff. And then this is just to give you an idea of what proficiency testing and EQUAS programs are available for proficiency testing. This is to give you an idea on troubleshooting in an ELISA. Specimen type and handling process problems. If you have hemolysis or hemolyzed samples, repeated freeze thawing of samples. That is one of the reasons why we say don't put a serum sample aliquoted. Don't put the whole sample at -20, take it out once, again put it back, again taking it out 3 days later, putting it back. All this can cause a deterioration of antibody levels with repeated freeze thawing of samples. Grossly lipemic sera, bacterial contamination with cloudiness. And on the other hand, you can have technical errors, which can be human errors in pipetting, procedural errors, laboratory errors. All these are problems. Yes, all the wells are colorless. What are the reasons for this? The conjugate was not even added. The chromogen was added to the wrong diluent. The conjugate is not diluted properly. The conjugate and substrate were added in the reverse order. That means before the conjugate, you added the substrate and then you're adding the conjugate. Obviously, there will be a problem. Reagents have not been brought to room temperature. All the wells are colorless. The second type. What is the problem here? Very low positive control values. What are the reasons? Inadequate controls were added. Your pipetting was not okay, or your tip did not deliver an adequate volume of the positive control. Your conjugate was inactivated. You did not mix the controls properly. You over-diluted the conjugate and under-diluted the wash buffer. Wrong incubation time and temperature. Inadequate washing was performed. Or you used a kit which has already crossed its expiry date. What's the problem here? Positive control is slowly decreasing over a period of time. Kits have been left on the work table for a long period of time. This is another problem. You take out your ELISA kits at 10 o'clock in the morning, and they remain on the workbench till 6 o'clock in the evening. The minute you finish adding your reagents, put them back inside the fridge. They must be at 2 to 8. You used a post-expired kit. Reagents have been contaminated. What is the problem here? Black specks have come up on the positive control well. Do you see this? I hope everyone is able to see appreciates the black specks. Precipitation of the chromogen reaction product. That is what has happened. All wells are colored positive. Where was the problem? Basically, inadequate mixing of the sample with the diluent, or the sample was added directly to the well followed by the diluent with non-specific binding of antibodies. There was inadequate washing or no washing done. Excessive incubation time and temperature given. Look at this. All the samples from D, E, F, G, H, all of them are positive. That means there was a carryover of one positive to the other. What was the problem? A new technician, new hand, untrained, improper pipetting, particularly when you don't dispense and you don't chuck the tip properly and you try to use the same tip, you can have one drop going from D to E, E to F, F to G, and G to H that is good enough to give you a positive result of D, even in E, F, G, and H. Intra-run failure of reproducibility. D was also added to E and to F and to G, but then they have all gone wrong. You have positive in D, but then you have negatives in the others. Again, pipetting errors, improper use of the washer, inconsistent incubator temperature, or a partial inactivation of the sample. So all this leads to very good maintenance of the equipment, proper training of staff. I'll just leave you with this. I think that's the last of it. I'll just show you a very brief video on ELISA. I'll just show you this one, and then probably we'll be short of time for everything else. Right. So the ELISA plate is out. Surendra, sir, can you come here for a minute? Then why don't I just tell what all steps? You've only done this, no?
This is diluted.
Right, sample diluent.
Controls and samples.
Right, so this is control and sample diluent, okay, being added. Initially in the tubes. Then the next thing is
Positive control.
the positive,
Negative.
right? So the positive, negative, and the cutoff controls that was shown
10 microliters each.
loudly. This is my senior technologist, my great friend, Surendra Reddy, who has performed the test in the video. So I thought it's appropriate to call him, drop whatever he's doing and come and talk to us on this. So this is
microliters each controls as well as samples. You have to dilute with 1 ml diluent. It will be 1 in 100 dilution.
I hope everyone is able to hear. Okay. Just move a little ahead. Now addition of the sample. This is the addition of the samples.
Always your pipette should be straight 90 degrees. Not like 45, 60 angles.
It should always be straight as he held it. Take a look at this. This is a very, very important part in serology, where pipettes are always held straight. Very often we find technologists holding pipettes in a 45-degree angle or a 60-degree angle. That is only done while splitting tissue cultures and virology. If you don't hold the pipette straight down, that is one of the reasons why your drops don't go in properly, because they go and sit on the walls of the tube. All right. This was just to show you that.
Mixing.
The mixing is so very important of the sample with the sample diluent. If the mixing is not okay, then also you can have problems, just as I showed you in the ELISA sheet. Okay. This is just to show you mixing in various forms. And then finally, adding those things to the wells.
You know, to have 100 microliters controls as well as specimens. Sample.
So this is addition of it.
Diluted controls and diluted samples.
So now you have the whole thing. Put a strip. Otherwise, if you put it inside the incubator at 37 degrees, the whole thing can evaporate. So to prevent evaporation, you need to coat the ELISA plate. What is the ELISA, this thing? And you put it in a very designated place inside the incubator. All right. Leave it for the amount of time. This is to prepare the wash buffer.
Wash buffer.
This is preparing the wash buffer.
10x concentration. For it, you have to take 90 ml water, distilled water, and add 10 ml of wash buffer, concentrated wash buffer.
So that makes it 100.
100.
All right. Mixing it well is very important, again, even for the wash buffer. And then you take it just for convenience in a sterile container. Now the plate is out. This is the washing step. Again, at every step, please note the pipette is always to be held vertical and straight.
Only single throw.
One single throw, you don't keep throwing everything, otherwise the bound antibodies also will get washed off. You need to be very careful. And no tapping of the ELISA plate onto the table. All those are wrong procedures. One single throw and just that much to blot off the excess amount of water. So if the manufacturer tells you to do this 5 times, you do it 5 times. If they tell you to do it 10 times, you have to do it 10 times. No shortcuts on that. Okay. Now the next is to add the antigen diluent. And then the antigen. Right. So first was the serum, then the antigen, and then the conjugate. So all of that.
.5 ml antigen diluent and 10 microliters antigen.
All right. So all this is added. Again, this has to be mixed very well.
Take equal amount antigen and antibody. Antigen 500 microliters what we were taking there, and antibody also
the same.
500 microliters. It should be equal volume.
Right. So once this is all done, it is put onto this
100 microliters.
Then you
into
coat.
all the wells.
Yeah. So now you add all of this to the wells. It's very important to be very sure about the volumes and the mixing of all this. Once this is done, again to prevent drying, you seal off the plate. Again, it goes inside an incubator some time, then it comes out. And now the washing step. Repeat the washing step is just repeated. All right. So I'm going to just run through this. And then finally, you will add the chromogenic substrate. You will add the chromogenic substrate. So once the substrate is added, this is kept for a defined period of time.
10 minutes in dark.
This is just about 10 minutes in the dark. We don't keep it in light. That's because so it is pushed inside the dark, kept for 10 minutes. Now you take it out and then you add a stop solution. And then we switch on the ELISA reader, leave it for auto calibration. And then when it says ready, put the entire strip or the plate inside. This is a strip cum plate reader. And then it automatically prints out your values. And then finally, this is the values. And then the whole thing has to go inside the sodium hypochlorite solution. Remember, all your sera are infectious. And this is the worksheet and the calculations which are being done for this. Right. So now I'm going to stop share and I'm going to stop here. The last 10 minutes, there are about 13 minutes left. And if there are any questions, Mr. Gautam, before we end the entire program. So, yeah, I mean, in effect, we have sort of discussed many portions of bacteriology that were possible, many portions of, an overview of serology, immunoserology, and a detailed on ELISA with its troubleshooting, the quality control and the quality assurance aspects, as well as a demo of how things are done. Mr. Gautam?
Yes, sir. I'm posting in the chat box.
Dr. Iyer, that is very thorough, actually, with a lot of videos, and I'm really impressed. You covered most of it in close to about 4 hours of your time.
It's fine, it's fine.
Not only your time, but you are a busy man, time taking away from your lab.
No, I'm extremely grateful. I mean, I'll finish that. Let me take this thing. We get a lot of slide positive Vidal, the tube Vidal turning negative with positive and negative controls being satisfactory. How to go about, other than Vidal in blood culture, other tests like Tubex or Typhi dot have a good role in serological diagnosis. Now, the first thing is, please don't do a slide Vidal. Vidal test is a wonderful test if you do it properly. You need to do only a tube Vidal test with proper negative controls. You can't be using a positive control because one does not exist in the kit. We always have a high titer serum preserved, aliquoted, and then we use it once in 15 days for our positive, once in 15 runs for our Vidal tests. But then the negative control has to be used all the time. And we always do a tube agglutination test and never a slide agglutination test. You have a whole range of false positives being given out in your slide positive kits, in your slide Vidal kits. That's why it is not recommended to do a slide Vidal. Any role of two-step MANTO in patients with first-time MANTO turning negative? If a MANTO is negative, it's negative. You can't be having a two-step MANTO in that. What is the cause of pan-positive ELISA? What do you mean by pan-positive ELISA? I don't know. You mean all the wells coming out positive? I think I dealt with that in the presentation itself.
Maybe that's what it means.
Yeah, carryover, essentially carryover.
That's it, sir.
That's it? Yeah, I think people are pretty fatigued and fed up of me.
Someone asked this question also.
What is your favorite food? What's my favorite food?
You talked about masala
proper vegetarian rice and curds. Rice and curd and sambar. I'm a proper Tambram. A proper Tamil speaking Brahmin. I love my sambar and rasam and rice and curd.
That's it, sir.
I think we are at the end of the questions as our IT support.
Before I finish and hand over to Kedar, I must thank some people who have been with me in this whole thing. Our senior technologists, one Surinder Reddy, who also talked a few minutes ago. I mean, he's done major portions of the bacteriology and serology. And then there was one Naresh Thakur Singh who did the tissue video. There was one video which I couldn't show for the want of time, and that was Mrs. Durga, who had done the colistin MIC determination. And of course, my colleague, Dr. Vijendra Kaule, who has done such a fine job of shooting these videos. I mean, I'm sure anyone and everyone who is attending or co-chairing this whole session will agree that these are some of the best videos that were possible with a hand camera. And he's really done a wonderful job. I must thank him profusely for making this happen. Otherwise, it would have been very, very difficult for us to show demonstrations in serology and bacteriology. Back to Kedar.
No, there's nothing more for me to add, but to thank you for your mammoth effort, Dr. Iyer. It is really wonderful. You spoke close to 4 hours. It was really hands-on, and I think it was will be very useful for not only technologists or MLSOs at various grades, but if any of our medical colleagues are attending, it will be also very useful to them. I'm sure of it. No, you dealt about troubleshooting, you dealt about quality control issues, and it also shows, we know that you wear another hat of, NABL inspector, ISO 15189 technical inspector, and it showed that from your records, from your slides, that how you looked into that and how to avoid actually problems in our daily practice. So I have nothing more to add apart from great, from the bottom of my heart, thank you so much for this. Actually, concept was yours, and I think the lion's share was done by yourself. So we are very grateful. At the end, I think I must thank Royal College of Pathologists for allowing us to do it. They have sponsored it. When we put the program, they said that, and very swiftly they said, okay, we'll do it for the Southeast Asia region. It was not our intention to charge anything because we thought it's an educational program which can be done free of cost. And we selected experienced faculty, and we really got very encouraging response. So we are very happy how it was conducted. We thank Video Technologies for their good and very excellent support. I once again request all the delegates to give us some feedback so that we can improve on the selection of topics, the way or maybe the time slot which is suitable, perhaps more suitable for the people in this region. And I think we will end on that note. So on Friday evening, I think Dr. Iyer, do you wish to add any concluding remarks?
Nothing. I think you've said it all.
I think we bid everybody goodbye and happy weekend for everybody. And thank you so much. Thank you so much. Thank you so much. Thank you.
Thank you.
Thanks.
We'll adjourn now and we'll end here.